And I always feel more comfortable when I work here because I feel that everybody knows what is going on. I don't have to worry about what they're gonna do because they know what is their role and they're gonna do it right.
The EP Center has 6 EP labs, 12 pre-procedure rooms, 20 patient rooms, which there are 4 suites for our patients to recover after a procedure. It allows us to have staff that are dedicated only to doing EP and providing the best care possible. A lot of EP labs across the country will have some of their techs and nurses will cover cath or they'll cover interventional radiology, and they're not purely doing EP.
What has changed is how many patients we can put through the study. Clearly, now most of the studies that we do are in the top enrollment if they are FDA IDE. And that's part of that is the fact that we can fit more patients through the lab because we have more space.
The option of bringing in research is easier, and the option of also spreading the message of what we do is a little bit easier because the new EP space is wired for that. We can transmit to other countries, and we've done that. We've transmitted to meetings all around the globe procedures that we do here so that other people can learn and interact across different borders and countries.
Everything that we do is driven by how can we make this more effective, better for the patient, and this go through our own study or collaboration with the industry to push new technology.
There's been a lot of different advancements. There's been advanced imaging that's come out recently, and now new advanced ablation technologies such as electroporation. And so that's all become interesting. And if you look at our experience here with it, we've already gotten a fairly large experience, in part because of our throughput and our size.
The reason why we push to have a dedicated space is because we strongly feel that that's the best way to provide better care. To have a team that is dedicated to caring patients with arrhythmia, it's really sort of the best environment to have the best outcome.
TCAI is the Texas Cardiac Arrhythmia Institute, and basically that's our group of electrophysiologists that are interested in advancing the field, doing research, and taking care of patients.
I think the people that we try to attract to our practice they all sort of meet the criteria in this commitment to research and innovation, which is really a sort of a strong differentiator of a standard sort of practice in US.
In 2019, we opened the EP Center, and it's a very unique place. There's not another one like it anywhere in the world.
I do cases everywhere across the nation, as many of us, and I always feel more comfortable when I work here because I feel that everybody knows what is going on. I don't have to worry about what they're gonna do because they know what is their role and they're gonna do it right.
The EP Center has 6 EP labs, 12 pre-procedure rooms, 20 patient rooms, which there are 4 suites for our patients to recover after a procedure. It allows us to have staff that are dedicated only to doing EP and providing the best care possible. A lot of EP labs across the country will have some of their techs and nurses will cover cath or they'll cover interventional radiology.
Switch
and
the
they're
video
not
off, please. Yep, thank you.
All right. Well, I know we lost a few people that are still kind of making their way into the room. And, yep, perfect. And Danita's sort of rounding people up. This is our section 2 or session 2, primarily focused on devices, but as you'll see, it's going to be a mishmash of cases. And I'm moderating. I'm so that delighted to introduce
learn and interact
Dr. Mark
across
Link, who is
different borders
one of my mentors and teachers from years ago, to be on the panel. Not that long ago. In addition, there is going to be Dr. Kamala Temarisa, who's part of our group, who will also be on the panel. once she gets unlost from being in the EP lab back to here. So she's going to find her way back. This afternoon, we have some live cases. We'll have a micra implant. We will have a lead extraction. We will have a left bundle area pacing. Those are all going to be live cases. Recorded cases, we will have two different electroporation cases recorded. One will be utilizing the Afera system, and the other one will be using the Boston Scientific Farapulse system. I'll present the case of force sensing catheter ablation, the new Tactiflex catheter, and we'll also have guest Dr. Valderbano talk about vein of Marshall ablation. There may be, try to see if we have this case available. We may be able to also show, I don't think it's on the agenda yet, a dual chamber leadless device that was recently put in, dual chamber Abbott device. So with that, I want to go ahead and have them perhaps queue up the first recorded case. That'll be the case Domenico's case. And Domenico may be online.
Good morning, ladies and gentlemen. My name is Domenico Giovanni Della Rocca. I would like to thank today Dr. Andrea Natale, Di Biase, Lucky Reddy, and Alamad for this invitation, and all the colleagues attending this very interesting meeting in person and remotely. Today, I'm presenting a case of pulse field ablation. I have nothing to disclose. The case is, the patient is a 58-year-old female with paroxysmal atrial fibrillation, first diagnosed in January 2021. The patient had a normal left ventricular ejection fraction and a left atrium of 35 millimeters. So we first performed a single transeptal and advanced a circular mapping catheter into the left atrium in order to obtain a voltage map. We then exchanged the transeptal sheath over the wire using a pigtail wire and we exchanged the sheath with the FaraDrive 15 French, the deflectable sheath of the Farapulse system. And this is the FaraDrive, and you will see it advance into the left atrium. We then advanced the ablation catheter, the FaraWave. The FaraWave is a 12 French catheter with 5 splines. We advanced a straight wire into the left superior, and then we advanced the ablation catheter over the wire and deployed it in a basket configuration in order to better cover the ostium of the left superior pulmonary vein. In this position, we applied a first pair of trains at 2000 volts. This is the first that you just saw. And then a second train of pulses. Then we kept the basket configuration. We rotated of 30 degrees in order to cover any potential gap at the ostial area, and then applied another pair of trains at the ostium of the left superior. We then pulled back the ablation catheter. We deployed it in a flower configuration and then advanced it in order to have better contact with the antrum of the left superior, and then applied a first pair of pulses at this position. This is the first one, and then a second one after 30-degree rotation. We then wired the left inferior and did the same procedure, like the first pair of a couple of trains in a basket configuration, then a rotation of approximately 30 to 40 degrees in a basket configuration, and then we came more proximal deployed in the ablation catheter in a flower configuration, as you can see here, advanced, and then deployed two couples, two pairs of trains at this antral position of the left inferior. You can see here. We pull back and applied some lesions in order to isolate the posterior wall. Here. Then we clock the device to move towards the right side, the septal side of the left atrium. Then in this position, we wire the right superior, and then we applied another two pairs of trains in this basket configuration for the left superior, and then two pairs in the flower configuration, always rotating after each pair of 30 degrees. Then we pull back the device, we deflected the sheath in order to fall into the right inferior. Then we pull back also the sheath almost all the way into the right inferior in order to have more space, to the right atrium, in order to have more space to advance the ablation catheter. We deployed the ablation catheter in this basket configuration and performed a first pair of trains in a basket configuration, rotated, and the second pair of trains in this basket configuration, and then the same was achieved also in a flower configuration. At the end of the procedure, we pull back the ablation catheter, we re-advance a circular mapping catheter, and then mapped, and this is the final result. As you can see here, right veins were isolated, posterior wall isolated, left veins isolated. This is the floor, it was untouched, posterolateral wall, and this is the final result. So in our experience, the mean procedural time is less than 1 hour, including from a vascular access to hemostasis. The mean isolation time is similar for the left superior, the left inferior, the right superior, is a little longer, is significantly longer for the right inferior, especially if the atrium is small. In this case, in addition to try the maneuver coming back and dragging back from the right inferior, another maneuver that can allow falling into the right inferior is deploying the catheter in a flower configuration on the posterior wall, drag back and clock the system towards the right, towards the septum in order, and sometimes it's easier, especially if the atrium is very small, it's easier to target the right inferior. Thank you very much for your attention.
Thank you. Domenico, are you on with us?
He's muted.
Can you unmute?
Can you hear me now?
Yes, yes.
Okay.
Where are you?
I'm in Italy.
Okay, very good. Congratulations, you're about to get married, right?
Yes, thank you.
I just wanted to see if there was any questions from the audience or the panel. I had a quick question for you, Domenico. In this procedure, are you allowed to do the posterior wall? And it looked like the posterior wall was complete when you finished. Was that intentional, or do you think it was just overlap of where things came?
So it was intentional, but in general there is like kind of a wide coverage with either with the 31 or the 35 catheter with the posterior wall once you go in the petal in the flower configuration. So there is a wide area that is covered, and if you stay like very antral, there is a big, like a decent part of the posterior wall that is isolated, even if you are targeting the veins. But in this case was done on purpose.
Domenico, nice case. I have a question. You know, when you started with the basket configuration, it looked like you were well into the veins, further than we would be with RF or cryo. Is that intentional, and is there any concern for pulmonary vein stenosis?
So it was intentional because we saw generally like we start targeting some potential that you see, and then right after the first train, you like all this potential disappear. So we start in general with electroporation, we start a little more distal, also because based on the data that we have available, the risk of stenosis is basically zero. So we feel more confident to go more distal if we see something and isolate everything and then come more proximal.
Great case, Domenico. Just a question, for the audience. Moving this catheter into the right inferior pulmonary vein, just like you mentioned about the left inferior, technically, is it more challenging than using the standard sheets, or anything that the audience need to, whoever wants to do these, should be mindful of?
So if the patient has a very small atrium, so we are talking about patients who have an anterior posterior diameter of like under 35 millimeters, it's kind of difficult to move and to go in the right inferior. So in this case, you can either go from the right superior and then drag it down. The risk with that is that sometimes the splines can overlap, and then it's kind of tricky and then you cannot deliver any pulse, and because the device doesn't allow for safety reasons. So in that case, it's kind of a little bit tricky the ablation catheter has to be pulled back in the sheath so that the splines can realign and then re-advance. So another way to do that is just have a flower configuration so that you can reduce the diameter, the anteroposterior diameter of the device, so you can make the ablation catheter flat, and that allows you to have to move a little easier in a flatter, smaller atrium, and then clock and pull back, increasing the deflection of the sheath so that you can fall into the right inferior. This is another way. It generally works coming from the right superior to the right inferior, but there is this chance that we observed sometimes there is this overlap of the splines. So sometimes you waste a little bit of time trying to realign the splines.
I have a question also about durability. So when you see early technology, it always looks better than often it turns out to be. What is your thought about durability of the lesions? And the second related question is a clinical one. Is it going to make a difference that you don't affect the ganglionic plexus long term? Will that make a difference in recurrence of AFib?
So in terms of durability, the technology is impressive, but it's not miraculous. And the more we use, the more we realize that contact is very, very important. So in case we have, what we noticed is when we see patients with recurrences, and we remember those patients generally because it was maybe hard to go into the right inferior, and generally the right inferior is the vein that is not isolated. Sometimes it's harder to move a little bit more anterior to the roof, anterior roof, to cover the anterior part of the right superior. And generally those are the parts where you don't see, where you see some degree of reconnection, as well as when you have very small atria and sometimes you cannot cover very well the posterior wall. You can see some degree of reconnection, but overall, I would say that it's the durability of the lesions. What we see in terms of recurrences are generally generally the veins are connected, and what we see is generally something that is not coming from the veins. So we had cases of patients that had recurrences, and then we mapped some triggers from the SPC or from the proximal CS. So those are the two main issues. So it's not, if we think that we are gonna resolve, like we are gonna have 100% success, we need to keep in mind that like a lot of patients, especially if we move, since the technology is safer, we are gonna move forward then to persistent, long-standing persistent patients, and those probably are gonna be the patients who need a more extensive ablation that is not gonna, and the success rate is gonna be low if we think to target only the pulmonary veins. So absolutely the technology is safe, is like durability is amazing, but we need to do some more, especially if we move forward to long-standing persistent patients.
Domenico, there's a question from the audience, and then I just had a comment. Can this be used to do mitral isthmus?
So there are experiences, and I think there is a case report from Europe, from Germany, that reported a mitral isthmus line that caused, I think, a coronary artery spasm. And but I know about cases that where the mitral isthmus was there was done, a mitral isthmus line was done, and it takes a little longer since the thickness of the tissue is and also we noticed a little bit of differences between technologies. So there are some catheters where you really need to, and it can be either because of the waveform, so the efficacy of the waveform, and also because of the deflection, so the reach of the catheter. So I think it's not just durability and transmurality of the lesion, but also how much you can reach the mitral, to perform an effective mitral isthmus line.
You know, when we've other technologies, when we've had recurrences with PFA and gone back in, we've found, for whatever reason, the right upper area is more of a problem.
I just want to ask one more question. Domenico, what about the MRI uptake in the aorta in the initial studies post-PFA? Do you worry about more damage? I know we are protecting the esophagus with this supposedly right now, but what are your comments on coronaries and the aorta?
So I think you are mentioning the study from Bordeaux.
Yes.
There was a study from Bordeaux. So apparently there was no negative result in those patients. I think there are so many things that we still need to understand in terms of titration of the energy to make a lesion effective. And also, I don't know, but my feeling is that we are underestimating the possibility of having some effect on other surrounding tissue, although it seems extremely safe in terms of like common complications that we have seen with cryo and RF, but this is something that definitely need to be studied in depth, as well as hydrolysis, as well as possible complications related to everything related to electroporation. I think we really need to study in depth all these possible complications that can happen in the long term.
Well, thank you for that great presentation. And maybe if we can switch to Dr. Burkhardt, who's here to show a different electroporation technology. If you're still available for another 15 or so minutes, that'd be great.
Hello, Burkhardt again. So this is a FARA, and as you can see, it's sort of a somewhat basket-shaped catheter. The good news about it is that it actually does two things. And so in addition to electroporation, It also has the ability to do RF. You see, as you see in the case, it comes with its own mapping system in addition. And so that's helpful not only in terms of location, but also in terms of contact for both the electroporation and the radio frequency. And so here's the beginning of the case that you see, just me mapping out all of the pulmonary veins. In this case, I did use a lasso at the same time just to confirm exit and entrance block and full isolation. The catheter itself handles very well, very similar to standard catheters. It's not remarkably stiff, doesn't have a lot of limitation, and it's bidirectional is probably the only thing I don't particularly like about it. I like unidirectional catheters. But even considering that, I was able to pretty much get everything else that I wanted throughout the whole case. This was, I think, my first case using this, and I think things went, overall, went very well. As you see, we're just kind of filling up here. In addition, you're getting local voltages off of the catheter, so you see areas of scarring, et cetera. You can do activation mapping if you like, in addition. This patient had been, was persistent that this trial is, and by the way, this was not a case involved in the trial. This was off the IDE outside of that. And, but as part of this, they're supposed to be persistent in the trial that's being performed. And this patient had already failed cardioversion, antiarrhythmic drugs, et cetera, and I think had been persistent for at least 6 months by the time that they had made it to the lab.
There's not a lot of signal in the veins.
No, deep in the veins, there definitely is not a lot. I used 2 different screens for this case, and so this screen is actually using using the Affera catheter. The next screen that I have, you'll see it pop up and down every once in a while, is actually the lasso. So we don't have those displayed at exactly the same time.
The voltage looks rather low. Was that confirmed with the lasso, or does the voltage just look lower with this basket?
It is, it's both, in that, yes, in this case, the voltage was low, but also the settings for the Affera catheter are a little different than we have the setting for our lasso. So they're not quite one-to-one, but yes, this patient did have significant scarring in their left atrium. What we do during this is that we go and, before we paralyze the patient, we check around the right superior pulmonary vein, trying to tag areas of phrenic stimulation. We do paralyze them during the actual electroporation portion of this, because you do get significant patient movement with the electroporation. The posterior wall is done all with electroporation, and there's actually a guide on the map that it gives you and you can see the purple, if you see the upper left on there, the sort of idealized map, that is how they determine on that map what is outside of the realm of the esophagus and posterior wall. So in that purple area, and if they turn that around AP, you would be able to say at those locations you can use RF, and the posterior wall, the grayish area, is all electroporation. You can also use RF along the lateral mitral isthmus to use that if you need for isthmus block. Hopefully you'll see later in this case that actually I just used IR electroporation in that location and had a significant effect on the electrograms in the CS. And so here you actually have skipped over, and we're actually starting ablation. In this case, posterior wall with electroporation. This is a little different. I think you saw Andrea do a case this morning. The time at a single location for the other technology is around 10 seconds because it delivers 3 different ones in that 10 seconds. This is very rapid in that literally it's one spot, it's a couple of seconds, and then you move it. You see that you get tags on their map. Green tags in this case are electroporation tags. It also gives you distance to the wall, and the color of the tags and the depth of the color give you your estimated sort of lesion with that. See, it screws up your EKG altogether, but that's fine. In this case, we did put the lasso contralateral to where we were doing the ablation. But this, and even as you can see, going over the areas that we have done, it very quickly just really takes the voltage down. Now here we're moving to the opposite side, so we skip forward here, moving to the anterior side, and you see we're using RF in these locations, particularly this is on the border of the appendage and left superior. And we switched to RF, and this, once again, just going very quickly. Did not see any heating on the posterior wall. We did use a temperature sensor in the esophagus, so no heating on the posterior wall using electroporation.
The anesthesia EKG looks great, but it really does mess with your EKG.
Yes, yeah, it does. And the switching in between them is literally just the foot pedal. You can ask the operator to change it, but if you just double tap the foot pedal, it switches from electroporation to RF energy.
Dave, what goes into that thought process of when to toggle?
Pardon me?
What goes into that thought process of when to toggle to RF?
Well, their recommendation is RF, anything outside of the purple zone. So anything that's not along the posterior wall, so anterior and lateral isthmus is using RF. Also, you can use it in the coronary sinus. In that case, they recommend electroporation IRE in that case. But here you see RF, and it gives you a very similar type of look in the RF, and that, once again, the depth of the color, it gives you both your estimation at your contact force there, how close you are to the wall that you've made, and the depth of the color is the quality of the lesion that you've done here. And so left vein, in this, we skip forward again, but left veins are already isolated and confirmed isolated. You actually see the lassos in the left superior vein, and that's isolated. And here, just finishing up on the right vein.
It's like from a versatility perspective, it looks like you can get just about anywhere with it, huh?
Yeah, you really can. And it's, like I said, this, in my opinion, performed really well, and particularly for someone who doesn't like bidirectional catheters, and for first case not being used to it. This went very fast. The entire, I don't have the timestamp on the video here, but after all the equipment was in, and testing the phrenic and things like that, we actually skipped over an important part here. But you see the distal coronary sinus, how it changed? And so, I don't know if you want to back up here, but if you can, but I only used IRE and not RF along the lateral following the coronary sinus catheter. And you see that was effectively isolated at the previous location. And then ablation along the posterior wall actually terminated this into sinus rhythm in this person who'd been in AFib for 6 months despite cardioversion, et cetera. And there you see pacing off that, again, the distal coronary sinus is isolated just with electroporation in those locations. And end of the case, just did the typical testing for the phrenic and isoprel, and that was it. And the patient's, this patient's actually already followed up and is doing fantastic.
So going back to the RF versus PFA, I guess I don't understand. If PFA is so good and great, why would you ever want to go back to RF?
Well, I think there's a good reason they did it. So if you remember the history of this company, they had, this is not their first version of this. And so their first version, and there's different mixtures of trying to figure out what is the precise recipe for the best electroporation. So their first outing did not go particularly well, and they did not, in some of what we saw with other technologies, the other companies that have delved into this, that they were seeing relatively high recurrence rates, and when they got in, they confirmed by seeing relatively high rates of recurrence of pulmonary vein conduction. And so what they did going forward was they changed both the recipe of their electroporation and added in RF in this. And there was still a feeling, even to relatively recently, that, for example, in the ventricle, you would not be able to use electroporation. That may not be true, and that further animal experiments have suggested that we may be able to get up to a centimeter of depth in areas with electroporation, which was not felt to be possible before.
So one of the, I asked Vivek the same question, and one of the rationales he told me was that, if you want to target GP anteriorly, this would be one way with RF, with those data, versus PF, where you likely won't target that region. So there's some scientific rationale for it.
Also, one study, they get approval for both potentially, so, yeah. So I was asked to make a quick comment that the noise level that you see with this particular case was particularly bad because they found a limb lead problem, but normally it's not nearly this bad.
What is the guidance on the RF duration and power?
It's actually preset.
There's only one setting.
Yes.
It's like 200
You can
watts.
do, there's one other, you can titrate up one setting for the mitral isthmus, and that's it. But otherwise, it's it very much like the electroporation is a single setting.
And the duration of the RF?
That one, it's like,
one setting?
yeah, one setting, and it's like 10 seconds. It's not very long.
In seconds. Yeah.
Does heat matter with the RF? Is it checking for heat, or is
Yes.
it just delivering?
Yes, so it actually checks the multiple electrodes on there, and so they do have and part of what they came up with is that was their formula for what was the optimal lesion based on optimal contact and where you wouldn't get steam pops and things like that, which is why they set that. But the heat matters in that they do look at the energy and how it's transferred, and that what is your contact and what is the local heat, and that's part of how they determined what is their optimal lesion.
I think that the current density is actually less than with RF. It's just a large footprint catheter.
Yes.
Okay. That was my question is, how do you know the contact, how much of current density, and it's interesting. But
I have a
looking
question.
at this looks much more flexible and easy to handle than what Domenico showed us, the
Yes.
basket.
Yeah, this is
displays.
very easy to handle. Absolutely.
And I have a question for Dr. Burkhardt. You have an impressive experience for VT ablation. In terms of maneuverability, not in terms of transmurality of lesion, do you think this catheter can be easily used for VT ablation? How do you see it in the future?
Yep. I'm going to put a caveat on this in that no, I don't think it's going to be great for VT ablation for the catheter because it has the exact same limitations of catheters that are used for AFib. I don't think it necessarily has the reach to get in all locations. High lateral mitral and things like that would be difficult with a sort of a single curve type of catheter in this case. So I think it does have that same limitation as most manual catheters do in that location. But it can be used, and it's not horrible. But I'll say here's the opposite of where it can be used. And like I said, you can put this in the coronary sinus. Pretty much most of the other catheters, you cannot put in the coronary. It's just physically, you can't do it. This you can put in the coronary sinus. We want to bleed in the coronary sinus. It's also, I believe, easier to navigate in the right atrium. And so, for example, I've got a case of that I really want to use this for. A woman who's had previous sternotomy and repair, and she's got a scar atrial tac that is right on top of her phrenic nerve. Is exactly what I would like to use this for, and I think it would navigate very well for that purpose.
Yeah, I just wanted to comment on PFA for VT in general. This is based on work from Jacob from our group.
It's interesting, you know, you have the versatility of getting into the CS with this, but the other one, you can just kind of put a big stamp and maybe take out a whole posterior wall, although I think it has a nose on it, so, you know, how easy it is to put it there exactly.
Yeah, but this, like I said, we covered the entire posterior wall in a very short period of time with this.
Yeah, great.
And I don't know if it's sorry. I don't know if it's just something that I noticed, but just going perimitral with a CS catheter, you can see like a significant signal elimination by staying in the left atrium, something that
Yes.
I haven't seen with the other catheters.
Yeah, that's what you saw.
Yeah,
in that
that's,
case.
in this case the case that we showed, you actually saw that the distal coronary sinus was isolated, and I didn't use RF for that. It worked very well.
Just wonder about coronary spasm, although it hasn't been shown that there's stenosis later of coronary. You damage the walls, I think that's pretty clear from the animal data, but it doesn't disrupt the architecture. It may not be a problem, but there has been coronary spasm. I just wonder how much of a problem that might be in the future if you're putting that catheter out and ablating the coronary sinus. It's not heat dependent, obviously. It's another mechanism.
And you can actually cause damage in the esophagus, but it doesn't seem to change the you know, cellular structure too much that it
Right.
doesn't end up with a fistula. So it's kind of an interesting technology in many ways. Regenerates.
And how about using this for typical flutter, right-sided flutters?
I haven't done it. I'm kind of curious about just the variability in pockets in the and how that would work. This one, the tip is relatively flexible, and so in those cases where you really have to dig down with a like a ramp sheath and an 8 mm catheter to get in some of those pockets, I'm not sure that this would necessarily get that. And if you have a space in between, I think it would work for the majority of them, but some of these difficult cases, you may have to resort to something else.
Very easy to do something with it. It's probably easier than any other catheter. And you can do the whole thing in like no more than 3 or 4 applications.
Wow. Well, that's a fantastic case, Dave. I think we want to move on. Maybe the EP Lab is not quite ready. They're setting up the micro now, so we should be ready to move to the live case soon. But before that, maybe we can invite Miguel to talk to us about a vein of Marshall alcohol application.
Thank you. I'm supposed to find an HDMI cable. Let me see here. I got it. All right. So, let's see. We are not happy with that. Do you have a drive? Or maybe I can try to find this place.
I did a good presentation just as cited a lot of reviews and just because it's such a cool technique, electrical pulses, and it's a cool technique. And I know the animal data and everything. No, absolutely. It looks so
Miguel, did you drive in or?
No, it was showing up. I flew in from Boston this morning. I was helping my daughter move.
You know, the MRI, I know.
Oh, I bet.
the
Where's he
MRI,
going?
Aorta uptake.
She's gonna be working in the Dana-Farber Cancer.
Yeah.
Just
They said
graduated.
no clinical, but they follow the patients only look at it.
It's showed up in that.
How do you want it?
Let me see.
I see it here on my screen.
You see it in yours? Okay.
I think it's just
Just a matter of time.
switch.
Oh, there.
There,
Okay.
that's perfect.
You needed some encouragement. Anyway, let me swap this place. Should be a way to swap this place. Hang on. Okay. This is a bit of a mess. Maybe here. Okay. So we'll be showing a case of venomartial alcohol as part of ablation of atrial fibrillation. Some of my disclosures. A brief discussion as to why do this at all. We have evidence from randomized clinical trials supporting the idea that when you add venomartial alcohol infusion to a conventional catheter ablation in persistent AFib, you get better results on follow-up. This is a randomized trial looking at data as randomized, including patients that were randomized to venomartial but that did not get the procedure because of technical difficulties, or as treated, counting only the patients that did get the procedure. In both instances, we have reduced recurrence of AFib at 1 year with reduced burden and a reduced need for repeat procedures, 17 versus 25%. In patients with persistent AFib, half of them had long-standing persistent AFib. So if we're setting up to do this, you need to get familiarized with specific equipment that will help you succeed. If you're using a right internal jugular approach, we use a coronary sinus sheath manufactured for left ventricular lead delivery, of any manufacturer will do. The idea is to get a stable CS cannulation. If you go from the femoral, I do recommend a deflectable sheath, Agilis or similar, to stay stable in the CS. Then to sub-select the venomartial, I typically use a Lima angioplastic guide catheter, but any of the left ventricular vein subselectors can help you achieve that. You need an angioplasty wire to get in the venomartial. You need a 2E valve for the Lima in order for you to give contrast, and an over-the-wire balloon. It's kind of a simple thing to remember that it has to be over the wire because you need a lumen to infuse the alcohol. And sometimes it's simply just the lack of familiarity of EPs with this kind of equipment is enough of a deterrent to not take on this procedure. I'll show you a case of a 67-year-old female with persistent atrial fibrillation diagnosed 7 years before. Symptomatic, she had undergone normal cardiac evaluation, normal echo, just diastolic dysfunction, pretty indistinct from other patients with persistent AFib. She had undergone an ablation 2 years before the current presentation without recurrence and with symptomatic improvement. But then over the past 6 months, she had experienced recurrence, and she had paroxysmal AFib and flutter on the monitor. So let me see how this goes. So here, the sound is not working, but that's actually okay. I'll show you. So this is an IJ, 9 French IJ puncture that I like to suture so that it stays in place while we do all the work. And the way I like to work is all in the right side of the patient as I would for normal work from the groin. So once we have this, we will get with a regular CS sheath. I think this is Abbott's or CPS, but anyone would work, and it is simple enough. We get in the IJ with the sheath and engage the coronary sinus. And once we have the coronary sinus engaged, I like to bend the sheath towards me because I'm working also at the groin. So instead of having another Mayo stand or something or a table next to the neck, I work all in the right side of the patient in the same working space. Then once I have, this is of course after you have CS engagement with the sheath. Then you go with the Lima. This is a short Lima catheter that helps us keep things reasonably sized and all within that space. If you use a long one, it gets a little bit more cumbersome. We will insert the Lima catheter in the IJ with a 2E and contrast. That 2E will be used to advance the angioplasty balloon and wire. But the idea is that you should be still able to inject contrast to get a subselective cannulation of the venomartial with the Lima. And this is the way you find the venomartial. You basically puff with the Lima pointing upward, And you will see it. Sometimes you don't. There's a fair amount of troubleshooting. Sometimes, depending on the anatomy, it is critical to recognize the valve of Usance here, and the vein of Marshall will be immediately proximal or ostial to the valve of Usance. And there's tremendous variability as to how close to the CS ostium that is. It could be 1.5 centimeters from the CS ostium. It could be as much as 6 centimeters from the CS ostium. But if you don't find that valve, it gets harder. It's a useful reference to have. I use a shallow RAO projection like this one that allows you to see enough of the vein of Marshall as a posterior structure to the main CS, and of course superior. If you go LAO, it tends to overlap, and you will not see it. All right, so we found it, and then we prepare in this case, we use a 2 French octopolar catheter. We're interested in understanding patterns of perimitral flutter and of mitral isthmus conduction, as well as other research opportunities that getting signals from the vein of Marshall gives you. So we will introduce that catheter at baseline into the vein of Marshall through that sheath. You kind of like to probe upwards. The whole thing will not get there. It's too big. It's too French. Back in the days when we had Cardima catheters, we could get much deeper. But this is good enough to get selectively in the vein of Marshall and collect signals from the vein of Marshall specifically. And we like to get a baseline assessment of perimitral conduction. So here we're pacing from the appendage. We have the ablation catheter, and we have constructed this propagation at baseline. This is untouched mitral isthmus. And of course, you have normal conduction, and the distal coronary sinus, which will be here, is ahead of the ostium of the coronary sinus, obviously. And if you look at the Bailey signals from the vein of Marshall, they precede the distal CS. Nothing earth-shattering. This is what you would expect. You're pacing from here, the vein of Marshall gets first, and then the distal coronary sinus. Fine. Then we go with the balloon and the wire. So we have we've chosen for this a 2 millimeters by 6 millimeters. We advance an angioplasty wire and we shape it in order to have some torqueability. This is, again, nothing particularly unusual in the angioplasty world. Give it some shape. And then we like to insert the balloon with a preloaded wire. This is important because if you put the wire first, then you need to have an extension length wire, which is 3 meters, and it's quite a pain to handle in the table. But if you have it preloaded, you advance both at once. And it can be a bit challenging. This is a stored fluoro. As you will see me struggling, trying to get the balloon is here, and I'm trying to get the wire to go into the vein of Marshall. It's useful to torque the lima posteriorly so that the lima is facing the roof of the CS and the posterior aspect of the CS. I'm struggling, and there it is. That's when I finally get it in. The wire is in there. When you get a little bit of wire, it's important to advance the balloon so the balloon stays in the vein of Marshall and then you don't lose it. And of course, you like to give a puff of contrast just to show that indeed the wire is gone in the vein of Marshall and the balloon is following. So then we get the balloon as distal as possible. This vein of Marshall was actually quite small. And we inject contrast. I like to inject contrast first without inflating the balloon. When you have it as distal as that is, the vein of Marshall can be very, very frail. And remember that what you want is to preserve the vein of Marshall and its connections with capillaries and the tissue. So if you dissect it, you may get staining, but if it doesn't get to the tissue, then you don't get the ablation effect. So this is first injection. You have some staining there. Then I retract a little bit, and then I inject 1 cc over 2 minutes. 1 cc of alcohol, 96% is what the manufacturer gives us. I like to inject contrast after to see this myocardial staining that you're seeing there, because that tells you roughly where the alcohol is going. So this is injection number 2. Then we retract the balloon, and we give a third injection. You see the balloon is partially inflated or barely inflated, and a fourth injection with the balloon halfway out so that we inject alcohol as ostial as we can, but as selective as we can into the vein of Marshall. Then we like to inject contrast to see that staining. And once we do that, I like to monitor on eyes the effect of ablation. You will see on eyes this tremendously echogenic area here, right where you would expect it below the left inferior pulmonary vein. If you use cartosound, you can actually outline it, and it will show you where this bright echogenic area, which is right on the left atrial ridge in the mitral isthmus. Once we have that, I like to go back with the 2 French catheter, and I like to reconstruct. I mean, I did this just for display of this case, but I like to see what is the effect of the alcohol. Again, pacing from the appendage, you see how we have changed propagation along the lateral wall of the left atrium. It seems to be blocked posteriorly, but anteriorly there's connection. We have some delay compared to before. Pacing from the appendage, we have some delay, but the distal CS, live wire 1, 2, is still ahead of live wire 3, 4, perhaps with some weight collision here because 9 and 10 are also just as early. So there's some delay. If you look at the Vano-Marshall signals, they're completely eliminated in the distal electrodes. So Bailey's 1, 2, you get only these low frequency far field signals, 2, 3 also, and 3, 4. Again, this is a shallow Vano-Marshall, so I didn't get it particularly deep. And that's the voltage map showing us the alcohol-induced ablation. So now we need to complete the mitral isthmus block. So what I'm doing here is I'm putting the ablation catheter in the annular aspect of the alcohol-induced lesion, and which is not ablated by alcohol. And you see the ablation lesion. I'm putting my catheter right annular to it, and we will start ablating at that point. And I like to do it while pacing so that we can track when the perimitral block is achieved. And I think this is it. We're burning, and at some point I'll show you the signals when the activation patterns change. So it's almost blocked. Live wire 1, 2 is definitely delayed, but at some point it will get unequivocally delayed, and suggesting, actually proving block. And the way we actually prove it is by showing also the Vano-Marshall signals that will become completely ostial. There it is, ostial to proximal, ostial to distal in the Vano-Marshall as well. It usually takes about 2 minutes of radio frequency. Of course, it's quite variable, but this is one way to reliably get perimitral block. These are the signals after obtaining block. We're pacing from the appendage. You can see how the Bailey signals activate from proximal to distal. You get some far field here, but clearly we have block. And the conii sinus ostium is first, and the distal CS is last. This is the final map, and this is how it's done. So a few key points. Myocardial staining is expected when contrast is injected in the Vano-Marshall after alcohol. Acutely increased echogenicity on eyes matches the location of the alcohol-ablated tissue. Incomplete perimitral block is usually achieved with Vano-Marshall alcohol, and they can lead to unusual propagation patterns in the mitral isthmus, as I showed you. But ablation annular to the ethanol-induced scar completes the ablation and leads to bidirectional perimitral block. Thank you very much. So specifically, I get the balloon as distal as I can advance it in the Vano-Marshall, and I'll do 1 cc there. You inject contrast ahead of the alcohol because you will see some patients will have collaterals, so capillary venous collaterals to roof veins, sometimes extracardiac collaterals too, and you want to see before and after. Typically, I give the alcohol over 2 minutes, 1 cc over 2 minutes. Why do I do that? Well, in the first case, the very first case I ever did, this was May 2008, I gave echo contrast, so Optison or one of those, and I gave it as a bolus, and the entire left atrium became white, and I almost almost pee in my pants, right? So am I going to give a bolus of alcohol in a patient? So remember, the IRB had approved one case, and I had to give them a report before they would approve the second case. So I gave it very slowly. And the interesting thing is that after you give it slowly and you let it sit there, it blows up the capillaries. So those collateral communications are not present after the first alcohol. So 1 cc distal, then I retract the balloon. I kind of divide the veno-marshal in 4 or 5 stages, and I retract the balloon 1/5 of the veno-marshal length, and then give another cc over 2 minutes, and I do that in 4 or 5 stages. The Bordeaux group, they are doing, I think they give 10 cc's on everybody, and they give 3 and 3 or something like that. They have had one case of what they thought was alcohol-induced anaphylaxis. I think it was just a bolus of alcohol. That is a potent vasodilator. So 1 cc at a time. The syringe has to be a small syringe because it's hard to push. So
I know it. I know that's why I'm asking, because people want to replicate. The other thing is, you are good at doing this now, but once you try to open this to many of people, I mean, there are possible complications with the cannulation, and they maybe minor, but they are there. And I learned from Andrea, we do CS isolation, and we go up and down into the CS. So, do you think that even without going in that vein specifically, with the heat that you deliver from the CS ablation, do you think we are able also to take care of any of these veno-marshal signals?
I don't dispute that if you're able to achieve transmurality endocardially with 100% reproducibility, probably you don't need to do this. The question is, are we there? And I don't know. I think there's so many cases. I didn't show you, but the second paper we published on this was looking at redo cases and patients that had been ablated extensively. All of them had like scar in the mitral isthmus, and all of them had very robust signals when you put a Cardima catheter in the veno-marshal. So transmurality in the rich is hard to achieve. It's possible that with electroporation or the Affera catheter, we don't need any of this. I don't deny that, but that's a hypothesis. This does it.
Miguel, if somebody ablates in the CS, is it possible to later do this, or does that trash the vein?
It can make your life miserable because having some degree of stenosis in the CS is very common after ablation, and the veno-marshal ostium can be compromised. I've had 1 or 2 cases in which we found another vein, an appendage vein more distal, and we injected contrast, and you could see the veno-marshal filling up retrogradely, but the ostium was occluded. So yeah, to me, if I do, say, if someone does a mitral isthmus ablation, so if I get asked by my colleagues that they've done a mitral isthmus ablation endocardially, and they're thinking about going into the CS, but they don't know whether to go into CS or to give alcohol, I beg them to let me do the alcohol first, so that the CS may not be needed. Although the truth is that if you need CS ablation, alcohol probably would not prevent you from needing it, because the CS is not really taken care of by the alcohol injection due to the dead space of the balloon.
So would you say, like clinically, you have a lot of experience, but just taking this home, would you say reserve this for people who had mitral isthmus line and couldn't get a block and then go do this?
I think it depends on your practice. So if your practice is 99% paroxysmal AFibs first case, you don't need this. But if your practice includes redos with atypical flutters, this is extremely useful. And as far as when to choose to do it, the way I see it is like conduction system pacing. If you do every single dual chamber, you make the ventricular lead a conduction system pacing, you get good at it. And when you need it, you have the skills. If you don't do any of this and you reserve it for the unusual case and becomes a whole adventure to do it, then it's going to be hard.
I agree with you because we do the same with the appendage. If you do one appendage every month or every 3 months, it's impossible.
It is impossible.
You do routinely, and we're doing that data. I mean, it becomes another vein.
Yeah.
Mm-hmm. Yeah. Absolutely.
So, for us,
No, so referring to the sub-analysis we did of the Venus trial, where we look at outcomes depending on whether we had perimitral block or not, and we saw that it discriminated. I think having perimitral block is just a marker of more robust ablation and truly a good job done. Because the recurrences were not particularly higher as perimitral flutter. They were just plain recurrences, fib and flutter and others. So I don't think it's specifically due to prevention of perimitral flutter.
Do you think we will need this with PFA now that we can probably...
I don't know. I tell you, I hear PFA, and what I hear about PFA is that it can be wonderful, but every time I see a case, there's some tuning of the waveforms or tuning of the parameters. It's like, okay, if you have to tune it, it's because it wasn't that wonderful to begin with. So there's a lot of empiricism here as to, well, we have to do this pulse settings in order to get permanent lesion. I don't know. I love the story.
Miguel, there's a... Miguel...
No, but I think that the nice things for the community is the same. Because I think that's important. And the fact that it's over is not a problem anymore. The pulmonary vein. I think
Yeah.
the people that do, if you look at the statistics, you were a caller in one of those. If you look at the statistics in the US, most of you do 25 cases, 50 a year. So for those people, the technology that doesn't cause collateral damage.
Yeah.
You're right.
Yeah, but for those people, cryo does a good job. I have to say that.
Still have issues.
Yeah. Yeah.
No. It's never 10 seconds. They're almost ready. They were ready for the micro, but there's an online question. I just want to get through that real quick, and then we're going to move to the live case. The alcohol seems to be very caustic. I've experienced difficulty pushing contrast through the catheter after the first CC. Have you experienced this? How do you circumvent this?
How do I circumvent what?
Difficulty pushing contrast.
No. I have not had. No. When you inject once and you inject contrast after, you will see myocardial staining, but it doesn't get harder to inject. Is that what you're talking about?
That's what the question was.
No. I used to flush it more compulsively. I just go alcohol, contrast, retract, alcohol.
You just got to push really hard, I think.
What's the difference between astronomy and politics? Because Venus and Mars got less advertisement than the Martian.
Yeah, that's right.
You should have going to politics from the beginning.
Exactly, yes. Thank you. I'll take one.
Well, that was good. Let's move to the live case. It's going to be a micro implant. Okay, David and Mohammed, can you hear us? David and Mohammed, can you hear us?
Yeah.
Okay, do you want to give us an introduction, tell us what's going on?
Yeah, one sec. We're just getting the perk closes set up, pre-closes. 1 second, okay? So this is a 77-year-old woman with heart failure with preserved ejection fraction. Here we go. The ejection fraction is about 55. And she's had 3 admissions for heart failure with preserved ejection fraction in the last months. So her requesting physician wanted treatment of her AFib, and we felt rather than doing atrial ablation on a 101 kilogram woman who's in her upper 70, she might do better with aortic ablation and leadless pacing.
Before you go in, so the slide can move from this that way to make sure that that's on top so it wouldn't smooth it. There you go.
So we're going to pre-close the vessel so that when we're finished, it'll be quite easy to get her up and about right afterwards.
And while you're doing that, maybe I can ask, since there's two of you, access, do you obtain it with ultrasound? Do you, what do you
Yeah,
do?
so before we got on, we get access with vascular ultrasound. And then we do two closes so that afterward, that 27 French sheath is easy to close.
Yeah. And it looks like you have a fairly heavy-duty wire there also, huh?
And so we're putting up a Amplotzer stiff wire.
Can you show us the screen also, guys in the back? So we can see see what they're seeing, not just the groin. There you go, thank you.
So the next thing we're going to do is size up. 16. We're going to size from an 11 French sheath. We're going to put in a 16 dilator, and then we're going to put in a biggie sheath. So we went from an 11 to a 16.
Okay. Yeah, you can move the camera down a little bit, whoever moved it. There you go. And from this, sorry.
No, but I mean, mentioned this. Her rate appears to be pretty well controlled right now. What's the advantage of ablating her AV node?
Question. Give me 1 second while I get this in, and I'll give you my thoughts. So she's at rest right now, sedated, and she's 99. My feeling is that when she's up and about, we've seen rates as high as the 130s.
Got it.
And doesn't tolerate much beta blocker at all. So, difficulty with rate control. Remember, we're seeing 100 to 110 right now, and she's fully sedated. Okay, so the Medtronic, can you hear me okay? I'd like to really wet this one down.
That's the microsheath you're putting in now?
Going in now.
Okay. And any tricks on putting this sheath in? I mean,
for me, two things. We wet it, and then we pre-dilation.
okay. Are you one of the people that rotates it in, or you just kind of push it in?
I push it in, and I do some rotation.
Do you need our heparin bolus?
Yeah, she needs 10,000 of heparin. Get the screen closer to us, please.
You need some heparin for it.
4,000 is what.
Yeah, I think it varies, I suppose. But
Maybe the patient's BMI, you know, I don't know, they didn't mention that.
yeah. One of the first ones we did, we struggled with because there ended up being a clot at the tip, and it took 7 deployments, couldn't get it. Then we pulled it out, and there was this clot adhered. But I think there's some variation in terms of heparin use.
Yeah, we've done a couple in people with thrombocytopenia that we've not given heparin.
And the other thing is the sheath is very hydrophilic, so usually using a 4x4 or something gives a traction on it. There's a kink there.
And we're getting some resistance right there.
Yeah, it looks like maybe some kinking or something.
Maybe injecting.
Ariopus.
They have an Amplatz super stiff, right?
That's an Amplatz super stiff, yeah. I think it highlights the importance of watching it go up, because if you just kind of push this sheath, it's a monster, and you want to make sure that you're getting it up there. And sometimes you do have to switch out the wire to something stiffer, and other times you have to take out the dilator on this and just dilate with this separately, because what you really want to avoid is this thing going in a different direction of the wire.
Right. concern of
You
the
know, even
peripherals.
injecting contrast sometimes. I have done one micra where the IBC filter was occluded, so, you know, we had to dilate through that and put micra through injecting contrast.
Yeah, it looked like your wire was already up in the heart, so we know that you're going through the
Yeah, my concern is the peripherals is what's hurting me here. The wire's not-
the wire came back a little bit.
What's that?
Well, while you guys are doing that, there's a question, maybe I'll ask the panel, and if there's anybody in the audience, question online. Do you close the skin level with something at the end? Example, Dermabond after pre-close.
No, I don't.
I usually don't.
No.
I've never used that.
Yeah, we typically use a figure of 8 stitch with O silk and leave it in for 3-4 hours.
I do the same, figure of 8,
yeah.
or I use the
Or the
pre-close and post.
pre-close, yeah. We've done it both ways, with figure of 8 and with pre-close, and it seems to work well either way. But you do have to make a big skin nick, and so I always wonder how those, they seem to heal okay.
It is amazing you don't get more vascular complications when you
Yeah.
see the size of that sheath. But we've really done very well with just a figure of 8. We don't use per-close at all, and most patients do extremely well in our ambulatory in 4 hours.
You have another.
And then I think the key is to keep dilating if you have difficulty.
Well, what I might do, guys, is we might go to a recorded case, give you guys some time to set things up again, and then we'll come back to you. Okay?
You come down to the. You guys have Clearsight also?
All right. David and Mohammed, can you hear me?
Yes.
Okay, we're going to go to recorded case and let you guys get set up again. Just let us know, okay? Okay. Can we switch over to the force sensing catheter ablation talk?
You can switch back to a different sheet.
Okay.
90% of the time I do figure of 8 for anything.
So I found out this morning I was supposed to do that force catheter. I thought it was actually going to be Andrea, but I guess it's me. Do we have those those slides?
Pulling it up now.
Thanks, Flex. Yeah. And I think, Matt, I'm going to have you scroll through it because you probably are more familiar with this than I am. So this was actually part of the clinical study with Tactiflex, and maybe fast forward to after we're transeptal. So the advantage of this is you sort of take two catheter platforms that are both pretty good. Tacticath happens to have a really nice force contact sensor, and the flex catheter gives less fluid and handles, in my view, handles a little bit better. So having the two together kind of adds a little bit of advantage. So here's the catheter in its transeptal, and let's go ahead and build the map, Matt, and go from there. Okay, so there's the map, and it actually has some other nice. They did some nice features to the way they display it. So now you can get a pressure that shows up on your map. So it actually is nice. I don't think they may have an arrow. I think they may also introduce an arrow with this version, which kind of helps you when you're kind of trying to point the anterior, also, or at least I think that's what's going to happen. Go ahead and forward to some ablation. Okay, here we go. And so the catheter actually performs pretty well. We've actually been pretty happy. Yeah, there is an arrow there, and you can see I kind of really like the arrow, in particular as you start to move towards the roof and start to move anteriorly, it sort of helps guide you to make sure that you're able to kind of slide along that and make sure you're not in the appendage, that your arrow is pointing away from the vein as you go more anterior. That I like. The other thing I like about this catheter is the way it rolls is nice. So, for example, you can take it from posterior to sort of anterior really smoothly, and sort of feels a little bit more like other catheters on the market that do that part well. You can see the arrow just switches to where you're pushing, and you can ablate really well. One of the problems with the tact-to-cath catheter is the amount of volume, in particular if you have to do a fair amount of ablation. So this actually kind of eliminates that issue where you don't seem to have the same volume problem. You can see the pulmonary vein signal. There's a slight bit of delay there as the catheter is kind of rolling around the anterior part of the vein. Maybe we can forward a little bit, not too much, just to sort of see isolation. It looks like this is on both sides, and you can still see the delay there, and then it's isolated. Up, and then it's back, and then it's isolated. So I don't know exactly when this will be out, but I think the clinical study is actually done, so it should be soon, yeah. Maybe fast forward to the right-sided veins. Okay, and then again, same kind of thing. You're able to really get the arrow directed nicely, so you can see that you're pushing up on the sort of septal aspect of the right-sided veins, or the posterior aspect, wherever you happen to be, which I think is actually a really nice feature with it. And maybe fast forward a little bit there. And that's the right upper is now isolated. It's in the right lower, and go ahead and fast forward through that. Everybody here has seen pulmonary vein isolation. Okay, keep going. And I suspect in this case we probably did the posterior wall. Go ahead and show us that. So I think there's a timer up just because the it's a IDE case. But you can sort of see the sort of scattered lesions on the posterior wall, trying to isolate the posterior wall as safely as you can. Power, I think per the study, was 35 watts in the posterior aspect. Normally we would go a little bit higher than that. So I think that's just a study restriction with this.
Actually, that's a good comment.
Yeah.
Cartiflex is actually a smaller catheter.
Yeah.
So you have a higher density component.
Yeah.
This is actually really a form of so you need to actually, if you want to make a good lesion,
You have to be a little.
way above 40 watts.
Yeah, so the comment is the TACTI-cath actually has a smaller tip, higher current density, and so at higher powers, you actually can deliver a lot of current and potentially have some pops and other issues. So just forward a little more towards the ending of the case. You can see just more lesions to kind of make sure that everything is truly isolated well. And then what we typically do is skip around in the sense that if you're getting some posterior wall heating, you move anterior or you move further away from the esophagus, because although contiguous lesions would be nice, the problem with that is if you're posterior, it's really hard to do that and still maintain safety. So it's been 20 minutes, and it looks like most of the posterior wall may be gone, although the lasso is not exactly there. isopril here. So that's ISO. And why don't you go to the 10-minute mark on ISO? Yeah, so after isoproterenol, typically we'll check. You can see there's a dissociated signal from the right upper pulmonary vein, or maybe is that the left upper pulmonary vein?
Yeah, left
right
common.
there, which is nice. Some APCs, so we'll see. Keep going. Yes, that's kind of it looks like just about the ending of the case there. I think it's just a quick demonstration to illustrate sort of what's coming out with the Abbott system, which I think is a pretty good improvement on both the Tacticath and the Flex, kind of merging what's best about both of them in one catheter with a pretty nice platform. So I think it's actually going to be a really welcome addition, although again, how we do ablation in the next few years may change dramatically with electroporation, so we're not entirely sure. Any comments or questions about this case?
There is a question. Is there a reason why he used the lasso over the HD grid?
Yeah, there is. I think the HD grid is really a nice catheter for atypical flutters. It's a really nice catheter for VTs. But I find for just the standard AFib ablation, it's kind of unnecessary. And then the other thing I find is that in order to know that you've isolated the vein, you kind of have to keep moving it around. Whereas if I put a lasso in, I'll know immediately which segment of the vein needs some attention. And so for me, it's actually a lot faster to simply use a lasso rather than the HD grid. I think it's a nice catheter, but it just really doesn't, in this particular, you're taking something and making it more complicated is the problem.
And for power settings on the posterior wall and the anterior wall, do you use just straight power and time, or do you use FTI or something else?
Yeah, straight power and time. So I would say what we gotten used to doing is ablating at about 40 plus watts in the posterior wall, but modulating time. So if you kind of go back and look at the cases and look at how much time is spent on a lesion, you'll find that the average is about 5 to 7 seconds posteriorly, 7 to 10 seconds more anteriorly in safer spots. You can definitely get away with ablating posteriorly more if you know you're far from the esophagus, and there's some ways of knowing that. Occasionally we'll inject contrast and see how big the esophagus is. There's some patients with small atria, the esophagus is the whole posterior wall, and so in those you kind of have to skip around a little bit and use short times.
Just a question. Do you use esophageal cooling device or, yeah?
I've used it in one case just to try it out. It seemed, the problem I have with it is it just feels like I don't know what's going on. When I used it, I just didn't know, am I successful or not successful? I know people that do use it and really, really like it, so I don't know how much of that is, is real, so.
Yeah, we use the esophageal cooling device not almost exclusively in our redos or when we're going to do a posterior wall. And I find, it's very nice because you don't have to worry about looking at the temperature.
Do you ever worry that you're not covering part of the esophagus and you're somehow missing something, or do you inject contrast and know for sure? Or how do you tell?
No, we don't inject contrast, but it's pretty wide too.
Yeah.
So I'm not that concerned about missing part of the esophagus. What I'm more concerned about is, the data on it is 120 patients, so it's not like there's extensive data. But in those 120 patients that had endoscopy, compared to those that cooled versus not cooled, the frequency of esophageal lesions was dramatically lower. But it's 120 patients.
And in a few years, it may be a moot point anyways, so hopefully that'll be the case. Why don't we move, unless there's other comments or questions, to the, you want to do the recorded Abbott case? Horton's ready? Okay, let's move on to 6 then for Horton. Okay.
Yeah, I use esophageal cooling device pretty much.
Hey, Rodney. Can you hear us? Bill and Rodney, can you hear us?
I can hear you, yes.
Okay, great. So looks like you guys have already gotten access, and looks like there's an ultrasound and a delivery system, and you're doing some conduction system pacing.
Yeah, we're just basically messing around so that I went ahead and put a quadripolar catheter. Hang on, can someone turn down our, getting a lot of reverb on our side? I don't need to listen to myself. At any rate, so we put a quadripolar catheter approximating where the hiss is. And I just wanted to sort of demonstrate where this is relative to where you're going to do a hiss catheter. Okay, you might just hold on that.
Yeah, so the quad is close to the hiss just as a demonstration, really not necessarily something you do.
And so, hold on. What we're doing is we're doing basically a pace map. If you'll look, the yellow electrode is V1, and it has sort of a QS appearance to it. And I'm counterblocking our sheath because we want it to basically go straight in horizontal in the septum. And I'm going to go ahead and rotate and try and get this thing into the septum.
So Rodney, I see an ultrasound image. Do you have an ultrasound catheter? I don't see that, or was it a surface ultrasound?
We're just doing it with transthoracic.
Got it. Okay. So once you get on the septum, in an area that you think is reasonable, you just start to screw the catheter in. Is that correct, or the lead in?
Yeah. And so there's a couple of issues with this. One thing you have to be careful is where are you going to start? Can you just hold it like that a moment? The other thing is you want the lead. So this is a 30-30 lead, which is a little bit like trying to screw in a thread. And so we want it as cold as possible because it actually stiffens up when it's cold. So I have some sterile ice cold saline, and I'm dipping it in that to get it as cold as possible. Obviously, when it's in the body, it becomes body temperature pretty quickly, but at least that gets us started. Because once you initiate the penetration into the septum, it usually goes pretty quick. Mm-hmm. That's the other issue. Hold that. Just hold the counterclock. Once that happens, usually it doesn't take a whole lot of turns for it to do it, and it should go in pretty easily. So again, we've got roughly the general ballpark of where we want to be. It's sort of an equidistant or QS. So now I'm going to start rotating it. And generally, if it doesn't start going in easily, you're not in the right spot because it should go in almost like butter.
Got it.
Now, a few other things that you'll see is as you're going, if it is in the right spot, it is getting deeper, the QS will change, and it'll still be a QS, but the S will become later and shallower.
In the QS, you're referring to which signal? The blue signal there?
Now, if you look at the yellow one, see how the yellow has that little, it looks like a W.
Yeah.
I'm going to go, we may be not in the right spot, so I'm going to start over. Again, this is sort of one of those things where if it doesn't go easily, don't fight it. It just needs to be in a different position. I want to make sure there's no tissue in it, because that will affect this.
Now, you're using the Medtronic lead. Are you concerned about using the other manufacturer's lead that have the retractable helix, that you won't be able to get it into the septum?
Yeah, I mean, I've seen some companies promoting their larger catheters with these retractable helices, and I had mixed feelings about it. I mean, I think
having a extendable, retractable lead has obviously some advantages. At least it'll transmit torque better. To me, that's useful. But if you do go all the way through and you have a 7 French hole in the septum, that may be more hemodynamically significant than this little 4 French thing. These, I just don't think this is going to be a problem if you go all the way through and have to start over. I'm going to take a few more minutes to try and get a little bit better position.
So there was a question about why you took out the lead, and I guess it was just checking to see if there's any tissue on it, and then also what he's been doing is putting it in some cold saline because it tends to be a little less noodly when that's the case.
Yeah, that's exactly right. Well, both of those are true. If you have tissue on it, you may not realize it unless you see it. And if you have tissue, you may have a perfect location, but the tissue is preventing it from going in, and you can't quite understand why it's not going deep. Now, this system obviously can be perfected, and this isn't, I don't personally think that this is a, I just don't think this is a final product, because, you know, if it was a final product, you'd be able to, you wouldn't have to unhook cables and plug them back in where you are. You could sort of see this thing being something. Now, that's fairly narrow. Now, what I don't like about this, and the reason I don't think it's good enough, is what you should see is that QS that I was talking about earlier suddenly being a QR, and the terminal portion being upright and lead decline.
I guess let me kind of ask you about that. When's good enough good enough? Because I mean, I looked at it and I was like, boy, that looks narrow to me. I'd be happy with that. But
yeah, it's. I mean, we may end up finding that that's good, but for the purposes of this, I really want to show how it's done optimally, if I can. I mean, obviously, better is the enemy of good, and I do understand that. But it's usually this is it's a quick enough process. It's a little tedious, but it's quick enough that it doesn't hurt anything to try a couple more spots.
Rodney, when you go ahead and start turning the lead, how many turns are you giving? Is it a feel thing? Do you turn and check? What do you do?
Yeah, well, you initially have to turn several times to basically engage the septum. If you don't do that, you're it's never going to actually initiate the process. So you need it. The first probably 3 full rotations need to be relatively quick and all of one.
And in your mind, has left bundle pacing supplanted HIS, or would you ever try a HIS bundle pace?
No, we used to do HIS bundle pacing, and honestly, we did it years ago. And the problem that I saw with it was that you had to be so precise and so perfect to actually capture the HIS. And you were very much like trying to thread a needle. And the problem with it was if it wasn't absolutely perfect,
470, 530, 530.
Yeah, morphologically. And so but the bigger problem with this, I think, is that even if you have a fantastic, that looks like it's capturing the HIS, it's very, very common for it suddenly have elevated thresholds. And so 3 months later, if you've got a threshold that's requiring you to pace 4 or 5 volts, you're going to burn up your batteries. The problem with the HIS bundle pacing, I think, is that you end up having devices that are lasting 2 years, and I don't think that's really very helpful to the patient. These generally don't go up because they don't have the fibrous body to affect that. So we're just sort of in around here.
I haven't found the perfect position. Okay, Carol thinks she's smarter than I am, so generally.
What did she say?
She said that's a better spot echocardiographically.
Okay.
Looks a little high. But Carol says it's good. I'm going to try it.
Yeah, so there's a question. Do you use transthoracic echo for all of your left bundle cases, or is this just because this is EP Live?
And I would actually love to. There's a few cases where we've actually used it because the things that you're looking for as you're advancing the left bundle lead is you're checking the pacing impedance. And if the impedance drops below 500 ohms, you frankly have to worry that you've actually penetrated the septum and the tip is sticking into the cavity of the left ventricle. And so we've occasionally had cases where the impedance looked suspicious, and so we used ultrasound just to confirm that we were not through.
Rodney, when you say impedance, is it the bipolar impedance, unipolar? What do you?
The unipolar pacing impedance at 5 volts. And that's, so this technique, I have to give a shout out to Dr. Huang in Wenzhou, China, who is sort of the one that invented this. And, you know, I've never seen a guy with better hands in my life. Got amazing skills putting it. He would have been the third case right now. That's how fast the guy. But he sort of explained what happened. So he had a fellow in a his lead, or was attempting to his lead, missed the his, and he really didn't just freak out and pull it out. He actually stopped and looked at what had happened. And he realized that facing the left bundle. And so then he truly decided, let's not panic. Let's just sort of see what happens with things over time. And so he followed a couple hundred patients. And what he found was thresholds never changed. They stayed low. And he found that if you think about it, the hiss is very small. It's a little bitty fiber. The okay, this is starting to look better.
That looks really nice.
R wave there. So the target is much larger because there's like this broad estuary of left bundle.
Rodney, what about, you said you liked ultrasound, but would you ever use ICE for this?
Well, yes, hold that counterclock. Yeah, you could, and we talked a little bit about doing it today, and it's like, I'm not sure I necessarily want to overcomplicate the thing. What was the impedance?
490s there.
Okay.
Got it.
So we've got a impedance that's just below 500 there.
504.
Okay, let's.
506.
So we're just above 500 there. Let's go on sensing and see if we can see a left bundle potential there.
In sensing, you're going to go bipolar for sensing.
No, this is unipolar.
This is all unipolar, okay.
I'm still basically just looking at the helix.
Got it.
What's the helix doing? Do you see anything there?
Yeah, is there a way to show the Medtronic programmer? Can you guys pipe it in with the signal?
Yeah, okay, hang on.
Unless you're using the laptop, the iPad one?
It's on the top left.
No, they've instead put the wound for some reason. The wound is actually not particularly interesting, but
oh, there it is. Okay.
Medtronic programmer is. Okay, so go ahead and paste there, please.
There was a little widening of the QRS there, yeah.
514. 514. Press down.
Okay.
Almost see that?
Where, can you see it on the septum? Carol?
Yeah.
Sorry, it is on the septum.
Point it out to me. Can you guys see can you open up the septum at all?
We can.
Yes.
We can see the Medtronic signal. We can see everything.
Okay, so go to 2. Let's see what the threshold is. Again, if this ends up being a threshold of 5 volts or above, let's go to 1 volt.
1.
I'm feeling lucky.
1
Let's
volt.
decrement from there.
Seems to be.
Yeah, it looks like
now
the
it's
QRS
actually
changed a
no
little
longer
bit.
capturing the left bundle.
Wider.
Do you see that? It's got sort of the right bundle branch block.
Yeah, yeah.
Yeah. So go up until it narrows.
Coming up. 3, 4, 5, 6, 7, 8, 9, 2. There.
Okay, so at 2, it clearly narrowed up there. So what I might do is take a little bit of a risk and torque it in just a tad more. Obviously, if you go too far, you got to start over.
Back to 5.
And now, Rodney, are you using the C315 sheath?
Yes, this is the deflectable sheath that's intended for this.
Okay.
And I'm also, what I prefer to do, what I found is that if you have a whole bunch of the leads sticking out the back end of the sheath, it's really hard to take the whole thing together. So I prefer to use a shorter lead, which barely sticks to the sheath. I actually have to take off the sewing ring so that I have just an extra small amount of area. That way, I have very little lead sticking out the back end. That way, it doesn't sort of spin around and become a knot. So, what's
Facing. Nice spikes at the beginning of the electrogram. 16 on the sensing. Hold it.
what was the impedance?
Less than that. Hold on. Wasn't sensing. Actually, small already. 2. Yeah.
Yeah. Run pace.
Facing.
And tell me what the impedance is.
522. 522.
Go to 2.
2 volts.
Go to 1.
1 volt. Changed again.
Okay, yeah, see, it's still between 1 and 2 there. Now, it might actually get better, but I'm going to try and just torque it a tiny bit more. Again, it's a little bit like playing chicken. If you go too far, you got to start over.
Back to 5 volts.
Go to 2.
531. 2.
And if you put in an atrial lead, do you usually put in the same type of lead, or do you use the other lead?
Sorry?
If you put in an atrial lead, will you use a 3830 for that to kind of match them, or doesn't have to?
I don't. I used to. What's the impedance?
536.
Okay, go to 2.
There's 2.
Okay, it's gotten worse. I'm going to go ahead and start over. Again, you just have to be a little bit of a perfectionist on this. A little bit. Sort of know where I want to go, so leave it right there.
It looks like you made a very small move there, because it looked like the spot you were in had a nice narrow QRS. You didn't have to move too much.
No, I didn't want to move too much. It's a good spot.
Rodney, what were you not happy with? There's a question from Rod Tung. What were you not happy with?
Well, I'm trying to selectively pace the left bundle. And you could sort of tell that it required around 2, maybe a little more than 2 volts to selectively capture the left bundle.
Yeah.
And I'm afraid I don't really want to leave a pacemaker at 3 volts if I can spend an extra 10 minutes and get a better.
But when it got wide, when he dropped it, that's
And again, I'm being a little bit.
I think it's a little bit of an affection issue in the sense that if you can get that narrow at a lower.
You know, if it's an extra hour, it's probably not worth it. If it's an extra 10 minutes, probably is.
has to be wide.
Yeah.
That's
Yeah.
right. And below.
Narrower version is non-selective, so he had non-selective to selective.
By definition, you're right.
This
Yeah,
part is
you're right.
false. Retreading the next.
But the torque on that one will be above 2.
It should be above 2. That's correct.
But I wonder if he
In
was
either case, it'll be above 2.
aiming for less than 1.
Once he faces bipolar, it'll be.
Yeah, I'd love for it to be, 0.5,
Yeah, we haven't checked bipolar.
something like that. That's what I would like. Can't always get what you want, but trying to get this as
and I'll just hold.
I would have taken that too. Maybe I'm not a perfectionist.
Let's just take a look before I drill it in. Okay, the morphology doesn't look bad, so you got the QS.
Yeah, you see that.
Looks like it's taken the cord.
Yeah, so there's a question about how much do you screw it in? What's the end point to be satisfied and how much
So
we
if
are,
you look, so here's what we're doing. So as I'm screwing it in, you see how it still has a QS. But the S is a bit later and a bit shallower than it was a minute ago. So that suggests that I'm actually drilling into the septum. The end point is you want to see that terminal S become an R wave. See how it's starting to become an R wave now?
Yep.
So now it's a QR, although the Q is bigger than the R.
700.
Okay. So we've got a little bit, so our impedance was in the 700 range. So we're, at least based on impedance, it would not suggest that we're almost through. So I'm going to go ahead and go a little bit deeper.
now, I've seen people inject contrast, Rodney. Do you do that also or not really?
I was planning to see how the R is bigger now. So now the Q is followed by the R, and the R is a little bit bigger than the Q. Can we,
535.
okay, so we're pretty close to where we would want to be on this thing. So can you come off and see if we've got a left bundle potential? We do.
Still sensing in the twos.
Okay, so go back on to 2.
Yeah, there's a sharp potential there.
Yes.
4 or 2 volts.
It's intermittent.
Yeah.
I'm going to just screw in just a tad more. Can't go much more.
Back 5. That's
Looks narrow. Looks good. Okay, go to 2.
487, 479. 2 volts.
Decremental
Still
here.
got it, yeah. Okay. No, that's losing. Right under 2.
We're still losing it. Just
2. Got it.
Okay.
9.
Does it typically get better?
That's actually getting, I think
It is getting better. So I'm going to go bipolar now.
Back to
I
5
do have to make sure that our proximate is extended beyond it. Okay, go ahead and. Okay, it looks like you're capturing both. So that's
790, 800.
so this is unipolar. So unipolar looks better than bipolar. See
That looks nice.
485, 487.
And that's bipolar. Bipolar looks like we're capturing RV, basically the right side. Now you can potentially just face this unipolar, you know.
Is there any circumstance where you just put in the atrial lead and kind of wait on this, give it time, or?
Yeah, that's probably what I'll do. I prefer the morphology with the unipolar, and as long as we have a pacemaker capable of pacing unipolar, then we're okay with that. Now our impedance was right at the edge of 500, so I'll definitely want to use the ultrasound, take advantage of the fact that the ultrasound, make sure we step and make sure we're not in the cabin. Ventricle.
2 volts. Still 470, 460 or so. There's it's getting better. There's 1.7, 1.6.
Hey, is it possible to measure the LV activation time in V5? So the stem to the peak?
Yeah, I'm sure we do. Can. So stem to the peak of, we'd have to be pacing, of course.
Oh, sorry.
In V5.
Facing.
So
Yep, update.
can someone hit update?
There.
and measure from stem to the peak of the R wave in V5,
Not to the end, the peak.
the peak.
Yep, there,
Yeah,
I can't see that number.
75.
75.
75, so less than 80. Yeah, 85.
Yes, you have a lot of nods in the audience. People seem happy.
So do we have some contrast?
Now, Rodney, given that it's tough to predict who's going to develop a cardiomyopathy from RV pacing, and probably the majority of people don't, what's your patient selection criteria for a left bundle pacer?
So that's an excellent question. So, it's a little bit trickier. Obviously, there's more nuance to it compared to just a standard right ventricular lead. Generally, as I'm sure you know, if you put lead in the right ventricle, particularly that's apical, we hope it doesn't pace. We have all these different software designs to try and prevent pacing, forced pacing in the right ventricle, because apical pacing is so artificial and potentially risk for creating a pacing-induced cardiomyopathy. So generally, I feel like there's a learning curve enough with this that if you do this and you don't quite get into the left bundle, what's the worst thing that can happen? Well, your lead's in the middle of the in the septum, harmful. It's not perfect, but it gives you another end to practice with. So I think you can't perforate unless you go into the left ventricle, but you're not going to perforate into the pericardial this. So I personally think that you have to kind of not to do it if you've got the. Because this is one of those things where you have to devote time, where you'll never get good at it. Then when you have a case that just depends on it, you won't be able to do it.
So then that's going to bring me back to one of my other questions is, Medtronic, I think, has the smallest diameter lead for this, whereas the other companies don't. They use their standard leads. Does this tie us into using Medtronic for all our cases, or do you think it's possible to use the other companies' leads to do this left bundle pacing?
Well, I think that at the moment, Medtronic has an advantage over the competition. Now, I just did an angiogram where you were asking that question. So you can sort of see the surface of the septum. You can see the ring is mostly, if not completely, embedded in the septum.
Yeah.
So both electrodes in the thickness of the septum. Can you see the tip of the lead?
Yeah.
Are you happy that it's not?
Yeah.
Okay. So we don't think it's through and through. We've still got a very nice left button. So I'm going to get rid of the contrast.
1.5.
Big injury, I'm sure.
Yes. Feeling's going down.
So the thresholds, the threshold's getting better. The R waves are everything's getting better. So I'm actually pretty happy with it, unless you guys don't like it, in which case I'll move it. I like it.
Yeah, can you measure the QRS width for us? It does look very nice, Rodney.
Yeah, now make sure, this is where I don't think measuring from the onset of the stem is fair, because some of these sort of have this still conduction, the conduction system. So you want to measure from the onset of the actual R wave.
Yep, that'd be fine.
Okay, so I need the atrial lead. So I think the KISS cap served its purpose. I just wanted to kind of demonstrate what that was. I don't normally do that. I just wanted to show where this is. This is generally a couple of centimeters directly across. It's not even toward the apex. It's almost like if you had a horizontal line directly toward the sternum compared to the HIS lead. If you had a catheter in the HIS, that's where, at least that's where Dr. Wong recommends.
Kind of 2 o'clock-ish, yeah.
And again, he's got the best hands I've ever seen. I'm just going to give him a shout out.
And in terms of programming this, you really don't need MVP, I suppose, right?
No, so I personally, once we started doing this, I put this in people, it's good, it's already fun. Whether they were going to use the ventricle or not, because I wanted to just get the opportunity. Are we still pacing? No, Mom. Okay. So now you have the option. You don't have to pace. You don't. I don't personally think that you need to force RV pacing, but this guy is having intermittent heart block. So it wouldn't totally shock me if 6 months from now you can't avoid pacing the ventricle. And so at the moment we could probably justify. Where's the straight stylet? So if we right now program it never to pace the right ventricle, that's fine. At least later, if he needs to, we're ready. And this is kind of it's a skill. And I personally think you want to have a few of these under your belts before you have a patient whose life depends on it or his LV function depends on it.
Well, let me ask maybe the panel and some of the audience members what their opinion is. If you have a patient where they've developed an RV myopathy, cardiomyopathy due to pacing, just traditionally we'll do an LV lead. Do you think that this is the time to do this? Are we ready for this?
Are you seeing T-waves?
Yeah, I'm doing this
as a first.
It's a different. I can't hear what people are saying.
There, we have maybe we can give a microphone out. We was asking the question is if you have somebody who develops a pacing myopathy, would you go with this versus LV lead? And Miguel's telling us he would.
I've been trying conduction system pacing ahead of LV leads. It's a matter of opinion. I realize there's no trial supporting that, but when you can combine conduction system pacing, when you get a R prime in V1 like that, and you still have already an existing RV lead, you can play with the timings and really get super narrow QRS, sometimes super physiologically narrow, and we know in this scenario that you're describing, we know the origin of the cardiomyopathy is RV pacing. So you correct that directly.
Yeah, I'm not saying I'm that progressive yet. I still would like to see larger randomized trials that directly compare left bundle pacing and CRT, because we know CRT works in a good percentage of patients. But I suspect you're right, to be perfectly honest.
It's too tempting. When you get super narrow QRSs, it's just even with the novel patients that have a cardiomyopathy and left bundle branch block, for a while I was doing both. I would put left bundle pacing and an LV lead, a bipolar LV lead, and connect them with a Y connector, and then choose. I'm not doing that anymore, but it's one of those things that I feel I'm seduced by the QRSs that you can get with this technology, more so than with LV pacing.
Now, are there patients where this simply doesn't work, no matter what you try? Yeah.
Well, similarly, there's people whose anatomy is unsuitable for their CS is suitable for an LVD.
Yeah.
But does everybody agree with what Rodney was saying, which I do agree, that you should try this on every single dual chamber pacemaker, and then you get good at it. Then it's not an adventure the first time the patient really needs it. Does everybody do that? Are you guys?
I agree with that, and that's what I do. I started to do this in clinical practice. If anyone needs any pacing, I just try the left bundle lead, because like you said, it's easy, it's quick, and it gives you that narrow, perfect physiological QRS.
It's easy and it's quick when you put 10, 20 cases into it, and then it's straight.
Greg, did you?
I mean, the counter argument of that is we don't know what the lead longevity is with this sort of flexion point. the numbers are great for 6 months or a year. We don't know what happens in 5 years or 10. And we don't know.
Here with his bundle experience, we already had disappointments. At least I had disappointments.
Right.
Good leads that sometimes they would dislodge 8, 10 months after. Or high thresholds. And this is an extraction we don't know about either.
Yep.
Yeah. Well, I mean, I think the other point is, I mean, how many times have you seen 90-some-year-old people with disasters when the lead goes into the apex, and I mean, it just goes right through. So, I mean, doing this, even if you didn't care about the capture of the His-Purkinje system at all, avoiding sticking leads in the RV apex is really an advantage. And so then, if you do this in everyone, and it's not critical that you capture the His-Purkinje, you can take the one that's difficult and just say, forget it. I'll take the septum because this one wasn't critical. Then when you start getting better at it and you really need to capture the His-Purkinje, you know what you're doing. So I mean, I'm fully in agreement with that, and particularly for these older people, we just see too many of these people come back.
And I think the comment you made is so key. No more we should be putting leads in the RV apex. I mean, long gone are those days. Every time, aim for the septum and then, apical leads, especially in elderly or even anyone, unless they're super thick hypertroph and RV hypertrophy. But
yeah, I haven't put a lead in the RV apex for ages. I mean, always put them in the septum, except in the one condition for a hypertroph that has an outflow tract obstruction. And for those, I want to pace apically. But that's the only patient now I'll put the lead in the apex.
Yeah, before this came around, I have to say, if I had a little old lady, if I did want to put a lead in, often I would just put a time lead in, because those really don't perforate. Whereas, and if they're 85 years old, the likelihood you have to pull out that time lead is pretty low. As a person who does extractions, one of the things that does worry me a little bit is how much that's going to get, how much tissue is going to come out when you pull that out if you have to. But I think we're going to learn. I think that's the beauty of it.
Just the comment, though, why I asked Rodney is when it went from 2 to suddenly wide, that's when it went likely selective.
Yeah.
And with left bundle branch capture, it should be wide. It's the opposite of His bundle pacing, where non-selectivity is wider with His. Non-selectivity is more narrow in left bundle. So he went from non-selective to selective, which is why I asked why he didn't like it. I think he wanted non-selectivity at 2, but when programmed outputs, it's going to be higher than 2 acutely, and usually these come down with time, and there's injury, et cetera. And then obviously bipolar, you get anodal capture, although anodal capture seemed like it was a little bit worse here. Can we get a final QRS measurement from STIM? I mean, that's the other question, is we always like to measure inside, but this is clearly non-selective. But usually these are still like 130. So it's rare to see these totally narrow with left bundle area pacing,
Any
which
chance
is
we
still
can get
okay.
a final?
And the other thing is we don't know if selective or non-selective is better.
Yep.
And in general, it probably doesn't matter because you're still going down quick on the left side in the LV. So to preserve LV synchrony is probably fine either way.
Yeah, I mean, I think overall you guys did a really nice job, and I think it demonstrated a lot of the nuances of it and brought up a lot of good points about trying this out. And I'm still in the beginning of my journey with conduction pacing, so I still have a lot to learn. I think it's really, really interesting stuff.
So this is the final out. We've already cut away the leads, so this is unipolar pacing.
Does anyone have any experience with the other leads, with Boston Scientific or St. Jude?
Yes. So they all have they're all stylet driven leads, and they all, like Abbott has their own His Pro sheath, Biotronic has their own Selectra sheath. So they're all developing sheaths, but you have to drive them in with stylet. And actually, it's sometimes easier because you have the backing of the stylet, and you go in. Longevity is not clear, but the shape of the sheath is what's key to get it in.
Well, congratulations, Rodney, on a fantastic case. We're going to go ahead and move on to the Micra case. I think they may be ready at this point.
Okay.
Thank you.
A lot, guys.
All right, guys. What happened? It looks like the wire had some difficulty, and then but now we're back up. Is that correct?
So what happened was, I'll show you some video here. This is all from the left subclavian vein. It kind of looks like we extravasated, but we didn't, fortunately. And we tried and could not pass that stricture point right there where the L is. Where the,
So there's some narrowing in the vein. This is from the femoral vein, correct?
Yeah,
Gotcha.
from the right femoral.
Yep,
So we ended up going to the left side.
got it.
And right now, because of her obesity, we're having a little challenge getting communication with the device.
So
Note to self.
where are you now with things? Show us,
So
if you can
so
show
we
us
went
the,
through the left femoral. We'll come down. There's the left femoral, and then we.
Okay.
And I'm in the ventricle now, ready to.
Keep that out.
it looks like you're ready to put it in.
Okay. So take that out. Okay, so we're across the outflow tract here, and I like a high septal position.
Okay.
So this is RAO. Now we're going to go LAO. Deep LAO. Deeper.
And now you're LAO, is that correct?
Yeah, we're LAO.
27.
Okay.
So we're doing a clockwise torque. And you can start to see a goosenecking.
Yeah, how much gooseneck do you guys like with this?
I don't like to push really hard on these ladies.
You don't or you do?
RAO, please.
I mean, I usually get a good gooseneck.
Where am I hitting? Go LAO.
I think the sheath is actually reasonably forgiving from that perspective. And the buckle on the sheath is actually not bad. the buckle
It doesn't
pressure.
transmit
Yeah.
to the distal end.
Yeah. Is that an LAO view now?
That's an LAO view now.
Yeah, it looks like LAO 37 there.
That's an LAO view. Deep
Further
LAO. I
LAO.
usually like a point towards the left a little better. Go RAO again. Yeah. But you can see we're pretty high septal out here.
Yeah, it does look like going from the left side may be a little more challenging from just the
Oh, yeah.
ergonomics of it.
We're going to take a quick venogram. We're going to take a quick picture with some contrast.
Okay.
I want to see how septal I am. And when you're doing this, it's important when you eject to remember to have your tether position locked so the contrast doesn't go out the back.
Yeah. And one of the things after I started doing this was when you cross the septum, try to cross it in RAO, and then after you've crossed, then you can clock it and then look
So
at
now I'm
LAO.
injecting contrast, and you can see it's staining the septum. Give me a higher flush.
Cross flushing.
And so you can see where it gets the septum right there.
Yeah.
So I feel pretty comfortable about that. The gooseneck looks okay. I'm just not a hard pusher kind of person.
Okay. Well, we can certainly see
how
how
we do.
it deploys.
So I've unlocked the tether. And if John's okay, I'm gonna see how we do with this.
Do you deploy it usually in RAO or LAO, or does it? Or do you
I
care?
deploy an LAO. We can go RAO. I'll go telemetry.
Can you guys show us the Medtronic screen also? Maybe can we get a bigger picture of things?
RAOs are 12.
It's a 1600.
Okay, so 1600 impedance, which I'm in love with right now.
Can we see more of your screen? Do you have the Medtronic screen up on the big screen?
We're getting it.
On the threshold now.
Okay, there you go. Yep, perfect. That's good.
We're good. All right, hopefully I haven't punctured. By the way, I use a clear sight. So you're losing a two?
Here we go. Going down. 3,
Give me 5 volts. Pressure value. What's that?
Alright, there's space at 5 and 100.
Right here? Yeah, you see the
It does look different, yeah.
So down at 4. 375. 625. Loss right there. 3.38 and 0.24.
Well, the impedance is a little bit on the high side.
Yeah.
So your threshold is what, and your impedance
High
is
right
what?
now, it's 3.5.
The threshold.
Yeah, 3.5.
Got it. And you have not done a tug test yet, so it sounds like this may not be an optimal kind of position.
Yeah, the impedance is way too high.
Okay.
1700, which is a little nerve-wracking to me. Take that thing out. Can you take your programmer off?
So you're still tethered, so you're just going to advance and kind of pop it out.
What's that?
You're just going to advance and pull it out at this stage.
Yeah, I just don't want pressure.
Let's read the blood pressure.
I want to check a quick echo when I see this. Recheck the impedance. Go LEO again.
It looks like your border looks okay.
Or I think looks okay. I want to check an echo real quick. Yeah, run the impedance value one more time.
Get another impedance.
Yeah, we've over the last several months, we've had a couple late perfs, which is really surprising to me because they did fine until like 4 hours later.
I didn't hear what you said.
And how were they discovered, Mark? Do they just sort of come in hypotensive at some
Hypotension.
point? Or, oh, interesting. And the only thing done was the micro, essentially.
And the numbers were all stable, right, at the implant and post-implant?
So our numbers are getting a lot better quickly.
625.
Yeah, we're coming down quickly.
We're down
I mean,
sub 2.
we're sub 2 now.
Sub 2, okay, that's good.
Yeah, 1.5.
But I noticed you've not done the tug test yet, so
I know,
although the
I've
numbers
done
are
tug
getting
testing,
better,
yeah.
you're not quite.
There's 1.
So we're sub 1 already.
Okay.
We're 0.75, 0.63,
0.5.
0.5, 0.38, 0.25.
There it is.
So 0.25. So we'll do a tug test here because.
And what's the pacing impedance?
Can you guys from Medtronic show us the pacing impedance? Maybe if it's possible to mag on it a little bit, just so we can.
Let's do that. Should I do it one more time?
Well, no, if you're comfortable with it, I'm okay with it, but we can't see it very well.
I want everyone to see it.
Sometimes magging may be a little bit.
We're seeing the times look great to me.
We're definitely seeing 2, maybe 3.
I'm seeing 3. I'm seeing the 2 top ones and the bottom one. You can see the 2 top and the bottom one. Yeah. So we've got a good tug test result here. Do you want me to do it again with a mag?
Yeah, or a different angle mag maybe would be good.
I'm not going to do it over there. It's magged up right there.
Yeah.
Can you see it?
Yeah, we can see it great now. Yeah.
So I think the 2 top
Yeah, it looks
ones
good
are,
actually. Yeah.
and the bottom one, sure.
Yeah, that actually looks really good.
All right. So we got a nice tug result. And one of the things I'll point out is I'm doing an AV node ablation on this lady, on this patient, and unless that threshold is sub 1, I don't even ablate because to me, you know, if I left it with a higher threshold, this battery is just not going to last because it's pacing all the time.
So you kind of wait, you might wait a little bit, see if the numbers get better, and then do it?
Yep. Well, so I'm going to cut now.
Okay.
How many of these have you had to retrieve, and how do you find retrieval of these?
You guys ready for me to pull?
Yep. Yeah, I don't think we've retrieved any here. There was, I actually don't think we've had to retrieve any. We've had one case where it was sent to us. It was a patient with a femoral device, and we actually ended up lasering out the femoral device because it was infected. It was coming out of his groin.
Too late.
But he had 2 micros in, and one was turned off. It was put in a different. One was turned off. One was on. And I guess the question is, we were talking about taking one out. It was relatively fresh, but you'd have to be sure which one.
Which one? I know.
All right. By the way, Amin.
Yeah.
On the right side, we used the 2 perclos, which was really helpful. I know I used figure eight up until weeks ago. And the reason why I switched back to perclos myself was the real downside of micros to me was that 6 out of bed. Some people figure eight only 3-4 hours. I've had some leads with that. So I think
there's a little bit of cutting out of your speech, but what I get what you're saying is that the perclos has sort of been helpful in terms of getting patients ambulating quicker and that kind of thing. There's a question, David, about the operator mentioned ClearSight. What was he referring to?
This is really, ClearSight is a non-invasive blood pressure monitor that is real time. And you can, on the real-time screen, you see it as reading 127/83.
Maybe we can take a peek at that. Can you show us the screen?
Essentially, it's a $250 finger cuff that is an arterial line. Can you see that?
No, not yet. So you use that as a surrogate for putting in an A line, say, if you wanted to do something.
That is a $250 arterial line that I use for these cases because if that, you're going to see a pressure drop on that thing. It's an A line, essentially. You're going to see a pressure
like an
drop
A-line, yeah.
before the non-invasive picks it up.
So what you're referring to is that red blood pressure, that red A-line looking thing, which is essentially, it's a non-invasive and it's...
Non-invasive A-line.
A-line, okay, very nice.
And when it goes flat, it actually gives the finger a rest.
Got it.
Now, is that the same as the Finipress? Because the Finipress was...
I found it much better than the Finipress. It's made by the valve people, Edwards Life Sciences. I use it on the pulmonary, my PVIs, even though we have echo guidance. It's just an art line. It's really nice.
When you're pulling the tether, David, are there any tricks that you've learned, or do you do it? How do you do that?
Thank you for asking. Good question. On the sheath, I give a flush of the a retrograde flush to make sure those tethers are really wet. Cut and then just pull slowly and steady, slow and steady.
Got it. And you'll often feel the heart kind of beating against your fingers
you
as you do it.
The first few pulls.
Yeah.
The 2 things I liked about this case that we just did, that impedance value was above 1,000, and I find that to be a very good sign. The other thing is that you saw, I'm sure a few folks who do a lot of these thought that the angle of the gooseneck was a little not so great because it seemed like that thing was pointing towards the right ventricle septum, but when we injected contact, the septal flush.
Yeah, no, we saw that. What was the pacing morphology in the end? I've found a lot of these look relatively narrow.
Yeah, so we're going to pace right now, and we'll show you the morphology. So I have my sheet, my 11. I have a short 11 and a 4mm sapphire. Yes, sir. Here's pacing. So we can hit end update and measure the QRS morphology. That's good. Go to DBI 30. Yes, sir.
144.
144, which,
Got
you
it.
know, for a single chamber is not terrible. That's an RAO view. And then let's go LAO for a second. You can see this is high septal.
And I guess another question is how high septal do you go? Because if you go too high, you could run into problems, and clearly you don't want the
yes,
apical.
so if you go too high, I think the risk is getting entrapped in the back of the pacemaker hitting the tricuspid valve. If you go too high. What do you think of that?
And there's also less trabeculation, so you may end up perforating.
Okay, so we're going to do the AV node ablation now. Okay.
Any comments or questions?
Usually I try to aim for the mid-septum.
Also, I also have an echo machine here, and at the end of the case, I'll do a quick echo, looking at wall motion, and I'll look at, make sure there's no pericardial fusion.
All right, well, very nice job, guys. We'll let you do the AV node ablation. And
I have to say, Mo was awesome with helping with the vascular access. That
good.
That's quite a challenge.
And maybe we'll go to a recorded case. They're getting the lead extraction is just about ready. We had some delays because the surgeon was still taking care of the other procedure.
There's a question.
Okay, hang on a second. Before we let you guys go, question is how much LAO is sufficient?
I got a 40 degree, but go LAO again. I just want to, what I like to do is that pacemaker should be looking right at us on an LAO view, just like that. And that's about a 45 LAO.
And I have another question. What do you think of the merits of this pacemaker versus the Abbott?
I didn't catch that question.
The merits of this leadless versus the Abbott leadless.
What was the question?
This pacemaker versus the Abbott pacemaker, the differences and advantages, disadvantages.
So my thoughts, I just got my training on the Abbott. The two things I really like, there are three things I like about that Abbott pacemaker. Sorry, Medtronic. Number one, that screw mechanism, it really is retrievable. Number two, there's a little hook on the back of it that when you pull it out, it can be extracted. And number three, the battery is, if you're using it as a single chamber pacemaker, the battery is really good. Like it could last up to 12 years, 14 years. The reason why the battery was made so good is because when it's used as a dual chamber device, it's going to use a lot of battery to communicate with the atrial device. So that's the advantage of the Abbott. Retrievability, and it screws in.
Although I don't know how much we have in terms of data on retrievability of any of these things.
Yeah, that's true.
Yeah.
Yeah, especially long term.
Yeah. Okay, well, fantastic job, guys, and thanks for hanging in there. We're going to, we'd love to hear about it afterwards, but we'll go ahead and move on to a recorded case.
Thank you.
So if you could pull up the recorded dual chamber Abbott case.
Hi, everybody. Here I am again. And I'm very
Take
happy
the volume
to introduce the first case of a dual chamber little pacemaker that we performed a few days ago in Milan, in Italy. As you know, the Avere dual chamber pacemaker is a natural evolution of the previous version of the NanoStim. There are needs and challenges with the dual chamber pacemaker in terms of the fitness of the device in the right atrium without interference with the valve structures. Should be a low rate of dislodgement and perforation, obviously, but also very good challenges. The right atrium is smaller than the right ventricle, is thinner the myocardial wall, and also there is a smoother endocardial surface, and we need also to take into consideration a much more dynamic motion. The Aware dual chamber pacemaker provides a atrial and ventricular pacing, has an expandable and extended longevity, and it provides a very good communication between the two devices, and eventually even the devices are retrievable, and the retrievability combined with the device fixation can open different indications scenario. The slide shows the main characteristics of the devices: the Aware delivery and the retrieval catheters. In the middle panel, you see the two Aware leaders pacemaker, and the devices are obviously aligned with the current Abbott platform. The current Aware is shorter than the previous NanoSteam, is larger, and is account for a higher battery capacity. But most importantly is the improvement of the helix action as to mitigate the risk of perforation or the damage of the helix itself that can occur during implant or repositioning of the device. Now, let's move to our clinical case in a young patient with a paroxysmal complete AV block. The first step was to visualize the right atrial appendage, and we saw the two images, and then we moved to implant as a first step the ventricle device. So we use a stiff guide wire. Then we prepare our sheath with a dilator as usual, and we introduce into the inferior vena cava. We need just to proceed quite gently across the skin and all the way up in the inferior vena cava. Once we achieve the right atrium, we pull the guide wire and the dilator out, and therefore we are ready to advance the Aware ventricle. The Aware ventricle is not pre-mounted, so we need to attach the device to the assembly. And here we have the example of the device over here. So we attach the device at the tip of the assembly as to make sure that
Another outage of electricity in Texas. What's going on, guys?
I know, he was getting ready to that, okay.
We lost the video.
Yeah, welcome to Texas.
We're working on getting it back.
Mark.
ERCOT. There we go, we're back. And, can you maybe rewind a little bit, because I don't remember him having already put that up.
Working on it.
That's the new look when you give a presentation, is the athletic gear with the...
and all the way up in the inferior vena cava. Once we achieve the right atrium, we pull the guide wire and the dilator out, and therefore we are ready to advance the AVEIR ventricle. The AVEIR ventricle is not pre-mounted, so we need to attach the device to the assembly. And here we have the example of the device over here. So we attach the device at the tip of the assembly to make sure that device can be advanced into the sheath and finally into the ventricle. So we introduce the device into the sheath, and we advance it, and we reach the right atrium. At this point, you can pull the sheath back into the inferior vena cava, and in order to facilitate the crossing of tricuspid, we suggest to move to the right oblique projection, as we'll see in a few frames like here, and we proceed to cross the tricuspid in order to position the device usually in the inferior apical portion of the right ventricle. Just it's also important to emphasize that we need to avoid any inferior portion of the left ventricle or the right ventricle to reduce the likelihood of perforation. Here, actually, we have the left oblique projection. We need to inject dye to make sure that we have a good position. Here we have the dye. And once we establish the good position, we move to the right projection again, and we inject dye, and you can easily appreciate that we are not at the inferior portion of the right ventricle. So we are almost ready just to screw in the device. And please note that in the center of the main body of the device there is a mark. So we need to follow up this mark, because once we turn the device, the mark itself is turning, and usually in order just to make the helix outside into the myocardium, just enough just to have 1/4 or 1/2 turn, as you can see in this example. And when the turning is completed, you can detach the assembly from the device, like in this case. So this is a portion of the procedure in which you need just to deflect the assembly as to move back and forth, up and down the device, just to make sure that the device itself is really attached to the myocardium. And then you proceed to test the biophysical parameters, the pacing threshold, the impedance, and the sensing as well. So once we are happy with the position and with the parameter, you can appreciate at the upper left end of the slide, and then we can proceed and finally detach the device and to complete the first portion of the procedure. Then we are ready just to position actually the actual device. So we need just to remove the sheath, reintroduce the guide wire, and reuse the same sheath to advance the actual device. And here again, we have the image of our our device just in place, and here we already we have advanced the right veer, and we have in situ the ventricle, and then we advance in order to achieve the right appendage that already we know where it is. So once we think to be in the right position, we inject dye, and actually here the first injection was wrong because we were into the superior vena cava. So what I did, I just deflect the system more anteriorly towards the appendage, and here we inject dye. And it's very important this step because when you have the staining like this of the roof of the appendage, you already know that you are in very good contact with the tissue. So what we need to do at this time is just to pull back more proximally the device, and then you can start to screw in. And this is a very important maneuver just to avoid perforation of the appendage at the roof of the appendage itself. So here we proceed, and we are almost, ready just to, I'm sorry. I think, okay, now we are again over here, so we have the right position, and then we have the atrial device, which is fixed in the most proximal portion of the appendage, the right appendage, and still we need the same maneuver. We need you to test the pacing like this over here. You can appreciate the sensing and the impedance. And please note, in the left atrial projection, in the right oblique projection, the two devices, and actually the position of the ventricle should be much more vertical, as to improve the communication between the two. And then note the atrial motion, and finally we had a very good communication between the two devices. And finally, this is the final picture with two devices, the atrial device and the ventricle device in this patient. And also I think that I need just to thank all the people who work in the lab that day in order to make this procedure very successful. Thank you for your attention.
I don't know if Claudio was able to join us. Do you know if Claudio's online at all? Or?
No, he's not.
It's too late. Yeah. Yeah, he was attending a wedding. He made it look easy, and that was the first time I've ever seen Claudio not wearing a suit. So he made it look easy, and he made it look good. We've not had any experience with this. Has anybody had any experience with this? Nobody yet, yeah.
I haven't done it personally, but in a couple of cases, one issue we identified early, I should say, is that the next day we're having difficulty with communication.
Yeah. Seems like that's one of the big issues with it, is how to communicate. But it really is crossing this incredible threshold where we can now do leadless dual chamber. I mean, it's insane that we can actually do that. It's pretty impressive. The device actually looked easy to put in. It really didn't look too bad, honestly. It seemed, he made it look easy at least. Yeah.
I haven't done any, but I've gone through the training, put in a whole setting, and the sheath logistics is, you have to pay attention. It's not something that you do it like, okay, tell me about it. You have to really go through it because it's complex.
We were probably designed by an interventionalist or something, yeah.
I have to say,
Yeah,
we really take care. I mean, like, we are very careful with the sheet management, but like, there are 6 poles.
Yeah.
They go A, B, and C, and one is contrast, and one is air, and there are the amount of steps to now, maybe once you start doing it, we do. But there are so many steps to do the delivery. Now, is the fact that you can, screw in and screw out, or you have a way to retrieve the device an advantage? Probably it is, but it's,
Let me
not
ask-
that, but the maneuverability of the sheet though was pretty good.
Very good. Yeah, Greg.
Well, I was just saying, there was a little bit of air, that's all bubbling up. You have to be pretty careful. Given that size of that sheet, you could get a lot of
Get a lot of air.
Also, Claudio is not here, but that position looked to me pretty apical
I
rather than
Thank you
septal.
for-
So,
know.
I mean, I was a little concerned, honestly.
Let me ask you this: do you get? I mean, for those of you who've been to the training or who've had at your center, do you get injury when you do this? Do you? How do you
get
know
injury. You get injury.
So you know that you've gotten that you're screwing it in. It's not.
Yeah, you get injury.
Yeah.
Yeah, it's pretty amazing when you look at the screw. There's not much room between the screw and the body of the lead. It's a little surprising to me.
Yeah,
There's not a high dislodgement rate.
That's the part that weirds me out a little bit.
Yeah.
Is the screw
Well,
is so close to the tip.
We'll see when we go into real life, in the trial is something. I mean, I think we will see dislodgement.
It's too big. Yeah.
I was surprised at how during the animal training that I was trying to retrieve it and I was having difficulty. Somehow snatched the whole device and just yanked it. And there's very little tissue on it. And it was surprising. What I was surprised about how hard it was to get it out.
Interesting. So even that small little screw is actually.
Yeah, the surface area looks larger for this for sure when compared to the Medtronic one. So the risk of perf looks lower, but I have no experience with these. But the location, I'm glad Luigi called it out because I was like, oh, that's too low, that's too low. Can we go up a little bit on the septum? But
Also, it didn't look like he had to gooseneck it or push it
Yes.
really hard. Is
Yeah,
that
yeah.
correct?
Okay, actually,
Oh, okay.
they say that's a huge. They don't want a gooseneck. They actually
That's what.
want the opposite.
So so it's
yes,
a lighter
that's
touch. kind of
actually
person.
they spend time on that.
Okay.
Interesting. And the electrical seems to be pretty good, although it's different. The Medtronic is at 0.24. This is at 0.5. Is that the pulse width is different?
Yeah, then you can map. You can see the signal easier than with the Medtronic one because that sensor there. So you can move the position. There are a few very, very good advantages.
Yeah. Yeah. Would you think that in the future we're going to be putting in all our pacemakers from the groin?
In the future, it would be nice. They're coming up with one that has a deep electrode that can do conscious pacing. Because you don't want to give that up.
Yeah.
It becomes a routine thing.
I think that's why the conduction system is there because they know that leadless is gonna be a problem. So it's going to be hard to do conduction system with leadless. It's very hard, I think.
Yeah, I'm still concerned about the long-term issues with leadless. And, you know, I think once it gets fibrosed in, it's going to be hard to retrieve. And so you're going to be stuck, you know, especially in young people, putting in multiple leadless pacemakers. And relative to the size of the RV and the RA, they're pretty big. I mean, they look small when they're outside of the body, but relative to the cavitary size, they're pretty big.
Yeah, you worry about multiple devices kind of banging into each other, and the concept that you can take it out seems reasonable, but when you sort of, if you ever have to, like you said, you pulled it out and it was hard to pull out, just give it a year or 2 or 5 years, and you know, this concept that, well, they don't get infected, I doubt that. They'll get infected.
There is also a technical limitation in my mind. Here, giving technical comment. So, the fishnet, how we call the things to grab the device is the snare. The snare is very good. You know, you go there and you snare it. But the problem is once you are on top of the device, they want you to slightly go back to the neck of the device. You cannot just snare. So you get it easy, but to pull it back slowly and catch the neck, that's a very difficult maneuver. I mean, you can be very lucky or not. So I think that takes a lot of effort in order to be, and if you're not there, they don't want you to unscrew the device. So I think that's actually not easy.
When you snare it, is the idea that you snare it and you just pull it? You're not.
No, you have to snare it, then unscrew, but they don't want you to unscrew if you snare at any position. You can snare any position, but you need to tie the snare when you are in the neck of the device. Hey, Miguel, you have that impression or not?
It's hard.
It's hard. It's very hard.
To go over the device, but then the actual grabbing point is very specific. You're going to come back and grab it.
But once
then
it's,
once you have it, it's very solid. You grab it.
Yeah.
One-to-one transmission.
with the snare. But are you really going to be able to unscrew it? Because if it's fibrosed in, yeah, that'd be short term, yes. Interesting.
This is very similar.
But it's the same body.
Yeah.
It's the same everything.
But it was all short term too. It was not long term extraction.
3 years.
Yeah, that's about right. Yeah.
So, but they get pretty fibrosed. I mean, they encapsulated the micro is mostly encapsulated
Yeah.
at that point. And so I could just imagine like 5 years, 10 years down the line being possible to get these things out.
But if not too deep, the screw, you know, you have to turn like 2 or 3 full turns, and it's not very deep. So probably when you're snaring after 5 years, you get a cheaper micro.
So the capsule comes out with it. Yeah. So there's a big capsule.
You know.
You just wonder how much tissue also comes out. I mean, when we pull out leads, sometimes there's little chunks of tissue on it that are a little, sometimes big. You know. There's a question, has there been human experience of multiple leadless into the same patient if a patient lives long enough? We've not had any experience with that. I don't know if anybody else here.
I've seen two two RVs in an individual, but that's the most I've ever seen.
And was that because of thresholds or
Threshold
issues?
rise. Yeah. So they needed a second one because of threshold rise.
I have seen a patient with two as well, with endocarditis, active endocarditis, putting Micra because the patient is status post AV node ablation and complete heart block. You know, thoughts on that? Do you use that, or would you go with an externalized, temporary pacemaker?
We've done it in patients who have been on so patients that are really challenging, where, you know, there's not a lot of great options. So what we typically will do is put in a semi-permanent and see if we can get away with that. On some occasions, we've put in micros as temporary, but ultimately they become permanent in infected patients with the idea that they're on antibiotics and they're cleared at this point. But I'm still a little bit concerned about that. And most of these people are not people that have the best prognosis anyways. So, I don't know that we're ever going to get long-term data on that.
We've been using, we have a very active explant program with one of our surgeons, and so we've been using a lot of micros in these infected patients.
Yeah.
But typically, we'll wait 2 to 3 days. But after 2 to 3 days, even with endocarditis, we've been implanting the micro, and I don't know of a single case that's been infected.
Because we've seen one case with a big micro suck it off, micro. This was an IV drug abuser. So, I mean, very, very high risk patient, but not like these can't be. They will get infected.
Yes. So just to repeat, because the virtual people can't entirely hear things, that there's been at least one case of an infection on one of these devices with a vegetation that needed to be removed, and then the device needed to be removed. I think it's real. I think that there will be cases of infection. I think we're sort of, be naive to think that it wouldn't. I think we will have to learn how to take these things out, and maybe the tools will get better for that. But right now, just yanking on something like this is.
The point is that they're probably more likely to get infected earlier.
Yeah.
Than later, because if they cut tissue, they probably have the surface.
To get infected.
Yeah, I've never seen an infected micro. And again, we have a very active explant program. We have Parkland, so we have a lot of IV drug users. And we implant relatively quickly after they're extracted. And I've never seen an infected micro. Oh, I'm sure it can happen, but yeah.
So I think, I'm just a little wary about the ones that are going in with active bloodstream infections. I mean, there's a chance that
We don't. We have to make sure their blood is cleared. Yeah, we don't put them in active endocarditis, but 3 days later we will.
I definitely feel more comfortable if it's a pocket infection. If it's a pocket infection, they're on antibiotics and they're in heart block rather than putting in a full, opposite side or something, a single chamber. It actually works really well.
Yeah, but that's where I saw those 2 micras in RV, but one was in the setting of active mitral valve endocarditis in complete heart block, and then had high thresholds and whatever, and then they put the second one in. And so that was the case, so I don't know.
When we've had good early results, it appears that they've stayed good. In other words, if we had good thresholds at implant, good tug, good everything, it appears they've stayed good. I've not seen people really have problems afterwards.
Agree.
So I'm waiting to hear from the extraction. They took a little while. They've already draped. They're actually getting access, working on both sides simultaneously, so they should be ready in a few minutes. We could take a 5-minute break, maybe something like that, and then reconvene. I think we can still finish up at about 5 o'clock as promised. So we just have one more case to go through, which is the extraction case, and I apologize, but it should be ready soon. So we'll do a 5-minute or so break.
Who knows? The battery problem.
I'm not either.
Hey, how's it going? Doing good. How about you? Yeah. How are you doing? Good to see you.
Candace, if I'm answering.